That's gonna be interesting. Thing I've always wanted to do, and I'm so lucky oh no, I'm not.
My 5-year-old is like already main stage queen.
Your daughter's 5 years.
5 years old. Yeah. Yes, they're 5 years. Yes.
Oh,
Yeah.
You're a 9-year-old and 5-year-old.
oh yeah, my sister is amazing. She is a godsend. Really, like if I was in the hospital, she'd come and visit.
Yep. Oops, as I fall apart.
Older sister too. It's hard to hear that.
So
Oh yes, yes.
we have a jam-packed program, so we are going to try and start and stay on time. So good afternoon and welcome to today's program. Title up there, Common Issues in Children with Williams Syndrome, Challenges and Solutions. I'm Dr. Barbara Pober. I'm a medical geneticist, and I've been doing this longer than most of you have been alive. Having set up the Williams Syndrome Clinic at Children's in 1987. This is Dr. Robin Tom, child psychiatrist specializing in anxiety disorders in Williams, and together we co-direct the MGH Williams Syndrome program. We're delighted to welcome everyone to this afternoon's meeting. We appreciate the effort you've made to be here today. We know it's not easy, weekend time away from family and needing to arrange childcare. So again, we genuinely thank you. We also want to extend some other thank yous at the outset. First, we're amazingly grateful to the Anthony Filipazzo Fund for Williams Syndrome Research and Advancement for generous support of this event, and the director of the Williams Syndrome, the Anthony Filipazzo Fund, Camille Fortunato, right there, and again, enormous thanks. We also thank the WSA, especially Sarah Giddings, for their support as well. Locally, Stephanie Turmel has been amazing at getting the word out. And we also thank Denise Callan, the walk coordinator for the WSA, helping us publicize the event as well. We thank all the faculty who are donating their Saturday time to come and talk to you as well. And our volunteers, Darren Chernicki and Meredith Pekunis. I said her name wrong?
Pekunis.
Pekunis, close enough, sorry, for volunteering today. And then last but absolutely not least is our program coordinator, Cherie LePage. For any of you who've talked to her, you know how amazing she is. If you haven't talked to her, she's hiding in back. And she's done countless hours organizing this event to run smoothly. And we're very, very grateful.
So to orient you to today's program, you all have an agenda in your packets. There will be 5 sessions with a break after session 2. You'll see on your agenda that for sessions 1 and 5, there are concurrent overlapping sessions. So please just select whichever is most relevant to your family. Session 1A is navigating a new or fairly new diagnosis. And session 5A is overview of neuropsych testing in the IEP. Both these 2 sessions will occur right next door. And all the other remaining sessions will occur right here in this room. Might be a difficult choice, but no worries because all of the presentations will be recorded and available online after today. And with that, let's get started. So if you're planning on attending Navigating a New Diagnosis with Dr. Pober and Terry Moncaba, please make your way next door. All right, so if you're in this room, that means you're here for puberty in Williams syndrome. And we are so fortunate today to have 2 wonderful speakers. We have Dr. Takara Stanley. She's a pediatric endocrinologist at Mass General with lots and lots of experience working with children and adults with Williams syndrome. And we also have Dr. Lisa Nowinski. She's a neuropsychologist and also the clinical director of one of our directors at the Mass General Hospital Lurie Center for Autism. Welcome, Dr. Stanley Nowinski.
Thanks so much. We're both delighted to be here. So I want to start off. So knowledge is power, and that's why you're all here. And worry often gives small things a big shadow. So some of the things that I talk about when I talk about Williams syndrome are things that could happen, but are not necessarily going to happen. Okay, so it's important to know what could happen, but it's also important to realize that they may not, and try not to borrow worry, as they say. So what we're going to do, I'm going to talk a little bit about an endocrine perspective, then Dr. Nowinski is going to talk about a psychological perspective, and then we hope to actually leave most of the time today for discussion. I am going to start with take-home messages. So children with Williams generally go into puberty about a year earlier compared to average. This doesn't seem to be pathologic or worrisome. They just, for some reason, seem to have slightly earlier timing. Timing is familial. So if everybody in the family went into puberty later, your child with Williams syndrome will also probably go into puberty later. It will probably just be a little earlier than the rest of the family. And early puberty doesn't necessarily require treatment, but you can stall puberty in some instances if it's desired, and we'll talk about why that might be. If you're going to do that, you can use something called GnRH agonists, which are medications that temporarily stop puberty. That doesn't necessarily stop pubertal behavior or sexual behavior, and we'll talk about that more. And then finally, from an endocrine standpoint, there are strategies for menstrual management that are safe and effective. So just to start with the usual timing of puberty, girls generally start breast development around age 8 to 13. And so in Williams syndrome, that may start as early as 7 sometimes. Pubic hair development is typically kind of along the same timing, but they actually are independent things. So it may not be. It's typically around the same time or a little bit later. And then periods usually happen about 2.5 years after breast budding. So that's an important message because a lot of people come because their child has just gotten breast budding and they're terrified that periods are like, around the corner next month. But it does typically take at least a couple of years. The average age of periods in girls is about 12 or 12 and a half. And so that's around 11 and a half in Williams syndrome. And there's a normal kind of range of getting periods, which ranges anywhere from about 10 to 15. When we're doing workup for early puberty, we consider it early if it's before age 7 or 8 in girls. And again, in Williams syndrome, that would be more around 7. If a girl with Williams syndrome had really early puberty, then we might look for a different cause of that. But if it's just early-ish, then we typically attribute it, and nothing else looks wrong, we typically attribute it to the Williams syndrome. So in boys, the first thing you notice in puberty is not something that parents would generally notice. The first thing that happens is the testes start to grow. So they get a little bit bigger. And once they're about an inch long, we call that the beginning of puberty. And that starts at about age 9 to 14. And in boys with Williams syndrome, it may start around age 8. And same with pubic hair, usually around the same timing, but can be independent. And puberty typically lasts about 3 to 4 years. So once the testes start to enlarge, that's the beginning of puberty, and it'll typically be 1.5 to 2 years before you start seeing a growth spurt or voice deepening. And so in boys, we consider early puberty to be earlier than age 9. But again, in Williams syndrome, I wouldn't worry unless it was earlier than age 7.5 or 8. So the next topic is medications to delay puberty, and these are not medically necessary. The main reasons you would do this would be psychological or emotional. The way we do this is with continuous administration of a hormone called a GnRH agonist. And this is a hormone that's actually made in the hypothalamus, which is right sort of above both physically and kind of conceptually the pituitary gland. When it's pulsatile, it starts puberty, but paradoxically, if you give it back at a really high level, it halts puberty. Names for this are Lupron or Triptadur or Suprelin. There's injections, that's Lupron or Triptadur or some other names. And then there's an implant, which you can see in the picture there next to the quarter, that goes right in the upper arm here and lasts 1 to 2 years. When puberty is really early, it may help adult height, but I typically don't think in general it's going to help adult height in Williams syndrome. Again, the reasons to do this would be if there's concern about maturity, concern about just trying to give more time for kind of emotional maturity to catch up with what the body is doing. So this can be very appropriate, and it's a child-specific and family-specific decision. But again, it's not medically necessary. There are some side effects, which is why we don't just do it in everyone. So you typically are building bone during puberty. And when you halt puberty with these medications, you're not building bone during the time that you're giving the medication. It does catch up afterwards, but that's why we can't give it for a long time. If people are relatively far along in puberty, let's say they've already had periods, and then you completely turn off their pubertal hormones, it's kind of like inducing a little mini menopause if it's a girl. So there might be hot flashes or things like that. Most data don't support it causing weight gain, but it can. And then there can be some issues with either some rash over the implant site or some pain with the injections. But typically it's relatively safe, and I have used it in a lot of girls and boys with Williams syndrome, usually girls. But again, it's a very family-specific decision. And the final thing I want to say is that we can manage periods. So the first thing is just that period underwear are fantastic now, like much different than if I were to give this talk 10 years ago. And they also have specific swimwear so that you can swim on your period with these specific underwear for swimming. Girls can also use pads or tampons, of course. And then there are ways to decrease or stop menstrual bleeding if it's desired. And that's for both quality of life and if there are difficulties handling either hygiene or kind of the psychological effects of menstruation. We can give birth control pills continuously, meaning you take one every day and you don't take the placebo week. That works in about 70% of girls. We can give a synthetic progesterone pill once a day. That also works in about 70% of girls to completely stop periods. IUDs are actually fantastic. They're the best means of contraception, and they also typically either reduce or stop menstrual bleeding. And then, a long time ago, we would see a lot of people with Williams syndrome who'd gotten Depo-Provera, and I actually don't recommend that. I don't know of anyone who's doing that right now, but I did want to just add that to this talk. And the reason is because it causes a lot of weight gain typically. I think that's my last slide, and I'm going to pass it over to Dr. Nowicki.
Thank you. All right, so now we're going to talk a little bit about preparing for puberty, and I'm going to cover a real range of ages and skills and knowledge here. And there may be a variety of folks in the room. Your children and loved ones may be at all different stages in this process, and we'll sort of pull all the pieces together. But I do want to talk first about why this is important, and it really is for a couple of reasons. So unfortunately, youth with developmental disorders are at higher risk of physical abuse or exploitation. And social and developmental delays can increase the possibility of engaging in inappropriate or problematic behaviors during puberty. And so it's really, really important that we give our loved ones the knowledge and skills that they need to be safe and healthy during this time frame. So it's never too early to start teaching about boundaries, consent, and safety. And we really want to make sure that we're preparing our child from an early age to have the skills and knowledge that they need to manage things that will come up for them inevitably through puberty. So what does that mean, right? How early is too early, and what is developmentally appropriate? We're going to talk a little bit about some general tips before we dive into the nitty-gritty. But in general, I want to encourage you to be proactive. I want to encourage you to be very intentional about building a foundation of knowledge early. So it may seem silly or unnecessary to teach the proper terms for genitals when your child's 3 or 4 years old, but that's exactly when you want to start teaching this information. You also want to make sure that your child is not skipping or being left out of any health or sex education curriculums. And this is tricky because in conversations with your school team, you may say, well, gosh, this course or this class isn't appropriate for my child's learning profile. So instead of opting out, I really want you to be proactive and advocating for the appropriate modifications, right? So your child should have access to all of the appropriate health and sex education curriculums, but they might need some IEP sort of specific goals and objectives built around that. And you may need your special education team to get involved in modifying that curriculum appropriately. And then I also just want to encourage you to find low pressure time. So if you can take anything away from this, I don't expect any of you to leave feeling like the expert, ready to have kind of a talk about puberty and solve all the world's problems at one time. It's actually much more helpful to have small conversations during low pressure times. This might be when you're riding in the car. It might be while you're taking a walk. But take some pressure off yourself. It actually takes pressure off your child and makes the conversations a lot easier. So how early is too early? We're going to start reviewing today some information that might be appropriate as young as age 2 or 4, so in early childhood. You want to be teaching your child about the names of body parts and anatomy. Make sure you're teaching the correct terminology for those body parts, and also start to teach consent. So make sure that you're asking permission before you touch your child, and don't expect or force physical contact, even with people like relatives. So hugs and kisses, we want to ask permission for those things. Make sure that you're providing clear instruction and also modeling public versus private behaviors. So this might be, it might look like making sure that you're intentional about getting dressed in the bedroom and not in the living room, even if in the course of your morning routine, it'd be easier to bring those clothes over to the table when your child's very young and get them dressed while they're finishing breakfast. There are lots of resources available, and we're going to talk more about some of these. I'll share many of these at the end, but for example, social stories, for example, can help teach some of these concepts early on. So just know there are tools. You're not left on your own to sort of create all of this information. As your child moves into school age years, I want you to think about making sure that your child knows that no one can touch their body without consent. Also, make sure that you're teaching your child that only doctors and parents can touch private parts. And if your child knows these rules, they're going to be more likely to tell you if something inappropriate happens, right? So being very clear and explicit with these rules is quite helpful. Also, help your child learn to be assertive, right? We want to make sure that your child can say no loudly and clearly and make sure that that is heard. So teaching that assertiveness and encouraging assertiveness is actually a really good thing. Sometimes makes your job as a parent a little trickier, right? Because they may use that protest skill in other situations. And then I also think you can do a lot of things to teach boundary and friendships and other relationships. For example, even when your child's in their school age years, making sure that you're modeling. Remember, we have to ask permission before we hug our friend, right? So a very appropriate behavior to give your friends hugs when you're leaving a play date or leaving the playground. Model that idea of consent and permission by asking your child to develop some of these skills early on. And then certainly even in the school age years, we're going to start to preview some of the physical body changes that we'll see in puberty, and start to build your child's understanding of what may be happening with their body through puberty. By age 9 to 12, in your preteen years, you want to make sure that we're thinking a little bit about teaching more specific information about puberty, reproduction, and again, those physical body changes. At this point, you want to start to make sure that you're teaching your child about the impact of their body hormones on both their body and their emotions. It's helpful to build consistency and independence with hygiene routines. And so even earlier, even in the sort of early school years, you may start to do things like teaching your child to wash their own genitals during bath time, right? Teaching that skills and independence is really early on is quite helpful in protecting your child's safety over the long run. Through these preteen years, we want to start to be mindful about teaching internet safety. It's really helpful to teach your child to identify inappropriate or unsafe behavior like bullying, sexting, or pornography. You want your child to be able to identify that and call it to your attention. Again, through puberty, lots of resources, social stories available to help teach the concept of some of these physical body changes. As you enter the teenage years, you're now sort of in the throes of puberty, right? But instruction around all of this doesn't get any easier. In fact, it gets more complex. There are more challenging and tricky topics ahead. And through these teen years, it's really important to provide really direct instruction about things like menstruation, nocturnal emissions, and masturbation. We're going to talk about some behavioral strategies in just a minute and have plenty of time for questions later on. But you also want to be teaching about things like consent in romantic or intimate relationships, teaching about drugs and alcohol. And I really encourage people to use role play to teach your child and allow them to practice how they might respond in certain tricky or challenging social situations. So all of this is to say we've covered everything from age 2 through teenage years, but it's never too late. There are actually a ton of resources available for adolescents and adults. So if you're sitting here today and sort of saying, gosh, we missed some of these windows, please don't panic. You may have to step back and start to build some of the foundational knowledge and skills, but it's never too late, and you can really use this information at any point through your child's journey. So I want to talk just briefly about some very practical supports, behavioral supports for managing puberty. In males, we're going to talk a little bit about how we manage and prepare for physical body changes, including things like creating a good plan for hygiene, exploring safe options or alternatives for shaving. And we also want to talk about how we manage things like erections and arousal. It's important that we normalize these physical body changes and physical experiences for our children, and that we create a safe time and physical space for pleasure or masturbation. It's really helpful to teach your child what to do, right? So these things are going to happen. You're going to teach your child that they may experience an erection, that could happen in public or it could happen in private. And you want your child to be prepared for sort of what to do in these situations. We also want to make sure that we help them navigate these normal physical changes with dignity. And so it can be helpful to think about different strategies like choosing clothing that may minimize the appearance of an erection in public, for example. Things like tighter fitting or snug boxer briefs can be helpful. And working with your child's special education team to identify if these are things that are happening in public or at school. We want to make sure that everybody's on board with a plan that allows your child the safety and dignity to experience these physical changes in a healthy and safe way. For females, obviously menstruation is top of the list. It can be challenging, but as Dr. Stanley said, with preparation, many individuals with Williams syndrome are able to manage their menses very effectively. And so we want to make sure we're considering all the different options, as we heard earlier, for period underwear, tampons, and other menstrual products. You're going to want to think about what's going to be the best fit for your child specifically, right? This may be based on physical abilities and fine motor skills. It may be based on sensory needs or preferences. And so really understanding what menstrual products are available and what might be a good fit for your child. And it may take a little bit of trial and error, sort of trying out different products and seeing what your child's most successful in managing. In addition to creating a plan for hygiene, around menses, it's also really important to give your child an opportunity to practice using menstrual products. And I would encourage you to do this even before menses start, so that they're not weird or unfamiliar materials, that they're available, that your child's familiar with what they are and how they're used even before she begins her period. I also want to make sure you know, and again, talking to your medical team, if menstrual suppression is something that you feel is important, if your child is having difficulty managing the hygiene around menstruation, while you're working to build some of those skills, there may be some menstrual suppression options that are helpful in reducing the physical management and stress around that. And just like with boys, it's important in girls to also be prepared to manage arousal. We want to make sure we're supporting healthy conversations around body image and normalizing the physical changes that our daughters will see to their bodies. We also want to make sure, again, just like with boys, we're creating a safe time and place for physical pleasure or masturbation. Again, being very explicit in our conversations with our kids about these expectations. And then just a couple of slides here before we dive into questions about healthy sexuality and sexual behaviors. Some of these things may be relevant and sort of at top of mind for your children, and others may not. So some of this may not apply to you. But I really want to make sure that we spend a little bit of time talking about the importance of recognizing that each person's interest in relationships may be different than another person, may be different than yours, and all preferences are okay. You do want to make sure you're teaching your child about different types of relationships, and it can be helpful to think about categories, whether they're sort of concentric circles, but everything from sort of a peripheral acquaintance, right, to a helper, a friend, a family member, all of those relationships becoming sort of more intimate, the closer or more proximal to the individual. You want to discuss with your children how relationships change over time. So this might be somebody who's a really good friend in elementary school, and you drift apart later on, right? You're sort of normalizing these changes and evolving relationships. And on the other hand, there may be people who were acquaintances who you become more interested in as you get older and move through puberty. When we're talking about sexual health explicitly, it's really important to think about role-playing consent and getting very practical and concrete with this. And we talk about sexual health, I would encourage you to think about this as sex or really any intimate physical contact. But you want to make sure that you're teaching about contraception and facilitating access as needed if this is something that you are concerned about or that your child is interested in. You certainly want to talk about things like the risk of sexually transmitted infections. And you also, through this period, need to be thinking about how you're preparing your loved one for important medical procedures like pap smears, prostate exams, and STI testing. And when we think about sex very specifically, again, this may be something that's on your loved one's mind and may not, but if it is, it's really important to talk openly about personal values and preferences, to think very critically and talk with your child about the readiness for intimate physical contact, right? How do we know if we're ready to kiss someone or to be intimate with someone? And again, talking about those risks and making sure that if this is something that is relevant for your child, that we're very explicit in talking about what sex is, how people talk about sex, and what people do when they have sex, right? So this is like really into the nitty-gritty here. And I want to pause here. I do have a couple of resources. These are developed by a whole range of different organizations and agencies. Some may be more relevant or less relevant for your specific loved one. We'll make sure that you have access to all of these resources. But I think they offer a lot of helpful tools to help you facilitate some of the conversations that I've suggested are important today. And I'll pause here just to see if anybody has questions for us. I think we've got plenty of time to take some questions and dive in. So feel free to move up if you feel too far away, and we'd be happy to take questions. Thank you.
So my child is, his name is Cooper, he's 12. And I've taken a really proactive approach. Exactly what you described. And I'm kind of patting myself on the back about that. It feels kind of good. Except I think I paused for a second because I noticed that at the age of 12, Cooper will perseverate about certain things that I'm teaching, and I feel like being proactive might give him ideas that maybe he's not having, and he kind of becomes obsessed with certain things. Like if I taught him about intimate relationships, he might therefore try to develop these intimate relationships at school, maybe he wasn't even thinking about that yet. How do I find the right balance?
Yeah, that's a really good
That's a great question.
No, geez, is this for recording? Do we know?
Because he knows like all the language around genitals and what girls have, and he knows about menstruation, he knows about erections, all of these things, but now putting it all together feels.
Okay, we've got you. I think it's a really important question, and it really is about striking a balance. I think one thing that I'd encourage you to think about is that you trust your instinct. You really do know your child best. And when you see somebody getting stuck in sort of a loop of perseveration, and you know exactly what's going to happen if you start to talk about sex or intimate relationships, right? That it may be okay to, as much as I told you, start early and be proactive, it may be okay to hold off on some of those specific content conversations while you're still reinforcing some of the foundation, right? Around consent and asking permission and physical body changes. And so I think it's okay to trust your gut and to follow your child's lead and know that some of those more advanced conversations, and I would say sex and intimacy falls in that category, are probably things that you want to be gauging your child's interest and readiness in before you offer that to them. There may be some people with Williams syndrome who not at all or not for a long time have questions or interest in that, and others who do show that interest earlier. And so I think if you're really watching and following his lead, you sort of won't go astray. So I guess I'm giving you permission. You've done such a good job so far that it's okay to sort of put a pin in some of those more specific advanced topics, because you know what will happen if you bring them up right now, right? And we won't sort of steer clear of reinforcing the foundation that you've already built around, using anatomically correct terminology, asking permission, understanding the nuance of relationships. And you may be able to slowly call out for him examples in older people or relationships that are present in his life, ways to talk about those things that he doesn't automatically apply to himself at 12. So if you're using an example of intimacy and people holding hands in a really, like, what does that tell us? We see people in public holding hands. What does that tell us about their relationship? Maybe pick an older couple so you can clearly paint the picture for him that like this is a tomorrow activity, not a today activity.
My son is also 12. Oh, sorry.
Thanks.
Hi, thank you. So my son, also 12 years old, he's been in puberty since he's 9. I haven't seen any type of emotional necessarily dysregulation. So what would we be looking for brought about because of the puberty?
Sure. So that's great that you haven't seen any of that, and not necessarily anything. It typically kind of 3 to 4 years after the onset of puberty, you'll be seeing, ejaculation at night or nocturnal emissions and things like that. And kids will typically start waking up with erections. If puberty lasts longer than 4 years, you might want to check in with your endocrinologist just to make sure it's still proceeding. But emotionally, and this is actually a point I wanted to make more strongly, and when I was going through my slides, pubertal hormones and emotional swings are very tied together in kind of our lay understanding of how things work. But actually, pubertal hormones can cause attraction and increase emotional feelings of attraction, but they're not directly tied. So that's completely fine. It doesn't mean anything's wrong. And everybody will, there are adults who don't feel attractions, and that's completely normal also. Yeah, you may want to add.
Yeah, no. Does that sort of get at what you're wondering about, or is there another layer that you're sort of curious about?
I've just kind of been waiting for the emotional roller
Waiting for
coaster
the
that
cliff.
I went through, and I don't see it with him. So I'm like, oh, it's not
That's
so bad.
great.
Yeah, that may be a win. Maybe take it as a win. That's right. Yeah.
Thank you. I guess I'm kind of like struggling. Our daughter is just turned 6, so she's on the younger side. But in terms of thinking about consent around touching, because one of the challenges we have with her is her autonomy in terms of doing so many things in her life. So I know with us and also in school settings, she needs a lot of physical assistance.
Yeah.
And so to there's kind of I feel like there's not a lot of space for consent when it's like a lot of time during the day.
Yeah.
And so I kind of struggle with thinking about how to deal with that with her.
Yeah, I think that's a really, really typical and common thing to be grappling with, because even thinking about how we teach skills and academic skills in school often requires some modeling or physical support or hand over hand support. And so there are going to be lots of places where your child does need physical support in order to learn or to sort of make it through an activity in the day. I guess I would say two things. I would look for opportunities to model consent, right? And so that might be with things that are more optional as opposed to the sort of required daily activities. So things like hugs, right? To say goodbye. How do you want to say hi or goodbye to grandma and grandpa, right? High fives, hugs, those sorts of things. So looking for opportunities that might be things that you just kind of pass over on a regular day, but really creating an option for modeling consent could be a helpful way to find those opportunities and kind of seek them out. And then I would also say that it probably is helpful to really narrate when you are going to be touching or offering physical support for your child. So if it's something like dressing, right, you can think about making sure you're narrating that, right? So it's time to get dressed. So dad's gonna help you take your shirt over your head, right? Or it's time to get ready for school. Do you want dad to help you to get dressed now or in a minute, right? In 2 minutes, right? Giving some choice and then sort of narrating what you're doing is not directly teaching consent, but it is in some ways serving the same purpose. The purpose really being that your child should recognize when something atypical happens, right? You want them to be able to tell you if something happens that's not normal or okay or safe. And if you're sort of modeling that sort of narration and offering choice in those situations, you're going to create a sort of safe way that you're offering physical support, and a difference between what you might do that's very appropriate and what another situation might look like that's not appropriate.
I add one thing?
Yes, please. Yeah.
Sure. Another thing, typically when many of us go to do pubertal exams, for example, we say, you know, we're doctors and we're looking at this because we're doctors, but it's not okay for strangers. And you could do the same with the caregivers, right? These people touch you because they're your medical caregivers, but it's not okay for people who aren't your medical caregivers. That's another part of the narration you can do.
Yeah, it's a really good point. Great question.
Yeah.
Changes to a body like for a female a few years after getting her period, like a quick sort of onset to a pear shape, and whether that'll be for the lifetime, if it's healthy or not.
Yes, that's a great question. And so typically, so after the period, girls continue to, I know this is not your question, but they continue to grow in height a couple of inches. And we do continue to increase our weight kind of far past the period. The body mass index curve continues to go up until we're, 16 or 18. So some weight gain is normal. Some people with Williams syndrome tend to be very thin, and some people with Williams syndrome tend to be more challenged in terms of putting on fat mass. And there is, and I'm not, you can tell me if you were asking something else, there is something that happens in some people with Williams syndrome that we call lipedema. And that's the sort of increased fat accumulation kind of around the hips and in the buttocks, and can go down the legs as well, and can be in the upper arms. Once that develops, it's hard to lose. So it's the best thing to do is try. I honestly, I think activity is so important, and really I think activity, because also of the blood sugar issues, is the most important thing to encourage in Williams syndrome. But really also, if you can start thinking about healthy eating and weight gain prevention, that's really fantastic starting around puberty, because it is, once that develops, it's tougher to address. Is that what you were asking about?
Yes.
Okay.
Thank you.
Sure. And that, I'll just say, it doesn't happen to everyone, and we're trying to learn who it happens to and who it doesn't and why, and we don't know yet, so.
Can you share how that works for boys after puberty, what the growth to expect, or does it stop?
Yes. So again, they typically grow for 2 to 3 more years after puberty. And typically the growth spurt in boys is kind of right at the end of puberty. So it would be before shaving. Typically by the time they're shaving, they've done most of their growth. But during the time that the voice is deepening, also typically you'll be seeing the growth spurt. And the kind of normal weight curve for boys is the same for girls, in the sense that we both genders, or both sexes, I guess, put on weight after puberty's finished. finished. But then we should all be leveling off, around age, 16, 18 or so.
You guys are doing a great job passing the mic.
Yeah.
Thank you.
My name is Jennifer, and I have a 10-year-old son, Gabriel, who is Williams. So my question is just about sort of really long-term trajectory. I'm just curious, how often do adults with Williams syndrome, establish long-term relationships, maybe get married, start a family? I was just wondering if just what sort of things to expect or hope for or to talk about in terms of possibilities for the future with him.
We can both tackle it.
Pediatrician.
We may even loop Robin in. I think I'd love to hear Robin's thoughts on this
Yeah,
as
Robin,
well.
great.
And others in the room may have some thoughts, but there's so much variability here that it's hard to sort of say what exactly the trajectory will look like for your son. I don't know if you want to jump in and see if you have,
Yeah,
go ahead.
Yeah, I'm happy to jump in because I see more of the adults with Williams syndrome. I think we see a very large range, like what Dr. Nowinski was saying. We see some adults who have very little interest in romantic relationships, but are very interested in friendships with the opposite sex. I would say it's common for many adults to have a romantic relationship in their lives. And I think what's important is to recognize that the term boyfriend or girlfriend can mean very different things to different adults with Williams syndrome. Sometimes it means like a person that you call every night at 7 p.m. And sometimes that means it's someone who you see at day program, and that's the person that you always want to spend time with on a regular basis. I've seen a small handful of adults with Williams syndrome get married. Oftentimes this requires a lot of support from both families to facilitate.
Thanks for jumping in, Robin.
Did that answer your question?
I think so. And then the second part is how often do they have kids? And is that something, a discussion we'll have to have?
Yeah, I certainly have met individuals with Williams syndrome who have had children. I would say that it's generally pretty rare.
I think our society in general could do a better job of not putting our gender expectations on kids, right? And so, and I'm talking about everyone now. And so, I think just being mindful of not putting expectations and letting your child lead you would be great. So, yeah, and I apologize because I mostly see kids, so I don't have a lot more to say.
Thank you.
Question. Thank you. Oh, let's go ahead. Oh, sorry. We'll come right over to you next. Yep. Either way is totally fine. Start here.
Okay.
Thank you.
Hi, I have a daughter who's 8, and we're starting to explore whether or not to do a hormonal implant. I don't even know if I'm saying that correctly, but delaying puberty or letting it naturally progress. I think my initial gut was to do some sort of intervention to delay it, but I've been reading some threads around like long-term effects in terms of like brittle bones, et cetera. So I was wondering what your sort of recommendation is if I do not think that she would be ready to sort of handle that and everything that comes along with it at this age.
Right. I think a team discussion is really best if you have all the providers who are seeing her. So if she has an endocrinologist and her primary care, I wouldn't just do it casually because, as you say, that there are any medical intervention has some side effects. I do think it's relatively safe if it's necessary. And so, and the other important thing is it's not like you go to your endocrinologist's office and you have to decide that day, right? So there's time to do it. As I mentioned, after someone started their period, there can be some side effects from the withdrawal of estrogen. However, I have had girls with various types of developmental delay who started their period and it was just unanticipatedly like really horrible. And we started it then for a little while until we figured out the menstrual suppression. So you never are cutting off all your options, if that makes sense. So I think letting your child kind of guide you as things move along and having a relationship with an endocrinologist so that you're talking about it is probably my best advice. I've done it a lot and we don't do it very long. And I think it can be very helpful. I think a lot of my patients and their families have been happy about it. But certainly I wouldn't do it unless there's a compelling reason.
And I wonder if I can sort of add a question onto that and maybe hear some of your thoughts, because one of the things that I would encourage you to do is to think about really dissecting the elements of puberty that you're most concerned about your child managing, right? Like, is it really the menstruation that's the thing that you're most worried about? And then is it better to think about delaying puberty entirely or simply thinking about menstrual suppression as an option, right? So talking with your child's team and care providers, it might actually be helpful to sort of parse things out a little bit more and say, are we concerned about my child's emotional reaction to her body changing? Or can we kind of normalize that for her? Is she going to be okay with her body developing breasts and her, physical appearance changing? But we're really worried about her ability to manage hygiene and menstruation. Those might actually be two sort of separate concerns. And there might be sort of a different approach you're thinking about taking from the medical perspective, depending on which part of puberty you're most worried about, right?
Okay, so I think what you're saying is that there's a difference between delaying puberty and then suppressing menstruation.
Yes, that's
Okay,
exactly right. Yes. Yeah,
Great.
yes. Yeah.
Thank you.
Not that we know of. The question was if there's any effect with delaying puberty on their glucose levels, and we're not aware of one. And, we have treated a lot of different kind of people with different diagnoses with pubertal suppression, and there's no evidence from that either. So I wouldn't expect that.
Okay, I always have lots of questions, so I'll try to, you don't have to answer all of them. Okay, the birth thing, I am not interested in raising a grandchild, ever. So is there, and I have a male, so I know like females can take birth control, but I'm just wondering, is there anything that you didn't already cover that can increase our chances of not raising a grandchild? That's one. Two, I went to the camp this summer and we had a talk. One of our sessions was about this, and all of the parents like were freaking out and like running back to the cabin and making endocrinologist appointments. So because my roommate was, I was like, oh my God, I got to do that too. So I did that. So we have an appointment in October. It's a endocrinologist at Children's, but is there like a guide somewhere of like what I hand to that person, or are they going to get it? Like, are they going to know why I'm there? And then his geneticist was like, I don't know why you're doing this. She thought it was a little early. Anyway, so I don't know what to do. My real question though is after the fact conversation. So like my son would be the one to break the consent. So like when my father passed away and people were people were hugging us at the wake, he was hugging he loved it. He was hugging everybody. And it's like, they're hugging me because my dad just died but like, you don't even know them. And I didn't hug that person. So I guess I'm sort of wondering, I find myself in those positions sometimes where like he has already sort of crossed the boundary. So I just like have a conversation with him after that? Or is there some specific language that would be helpful if I miss the opportunity?
Awesome questions. I'm going to try and tackle 1 and 3 and then pass it to you.
Okay, I have notes if you forget what.
So let's go ahead and start with number 3 that you're talking about, sort of if your son has already breached consent, or you haven't, been able to kind of intervene in that moment to help support him through seeking appropriate consent. A couple of things. You can talk about it after the fact. I don't find that that's necessarily as helpful in changing behavior. If you can anticipate situations and grief and memorial services are a really hard one, but if you can anticipate situations that might put your child in a position for, sort of uncommon or unexpected physical contact, having somebody that's sort of assigned to shadow your child to be able to prompt them through that consent process in the moment might be really helpful. So is it possible for a teacher or an aide to come with you to something like that? Is there another maybe more distally removed family member that could sort of stand with your child in sort of a greeting line and prompt them through with questions like, oh, do you know this person, right? Oh, do you want to give a hug, or would you like to give a handshake? And so you can have, if prompting in the moment is probably going to be the most effective way to support learning. Your first question, I think, was really maybe speaking to the limitations of male contraception in the country. But I think you're really going to have to gauge how much interest in physical intimacy your son has. And if your son is demonstrating significant physical interest in intimacy, then I would really, really push things like access to contraception, right? And make sure that he knows that that's like not an option condom needs to be used every time, that he knows how to use that he has them with him all the time. You're going to set him up for the best chance to use that contraception if he really is aware and has access to that. But I would do that following his lead. If he's showing some interest in that degree of physical intimacy, again, he may not, right? So following your child's
So
lead
to the
may be
point
helpful.
about like perseverating or like jumping the gun, like I don't need to be like, this is a banana and I want to show you how this condom can go on it. And it's similar to your penis. Like I don't need to be jumping the gun on that.
I wouldn't. I think that in general, other clinicians may have sort of differences of opinion on that, but I think I really would follow your child's lead in that more, and maybe be asking some proactive questions to feel out for their interest in physical intimacy. So you're not just waiting to see if it happens, but you're kind of gently feeling that out occasionally throughout the course of puberty and adulthood. Yeah.
And I would say different endocrinologists have different kind of spectrums of experience with people with developmental delay and different opinions about the use of these medications. However, the endocrinologist should definitely know why you're there, and there are resources on the WSA website that are fantastic.
Sorry, one additional question. Teenage girls is a thing. At the moment, he's involved in some programs, and he is very drawn to teenage girls, and he's 9. Yeah. Should we? Yeah. Okay. So should we just? We know we can talk to him about boundaries, but for these programs, should we be specifically providing, I don't know, instruction or documentation to the program leaders that for our son's condition, this is what we would like you to do. So just general question there. Maybe it's an obvious answer.
No. I definitely would. I think this is part of you as parents and caregivers being proactive. And so wherever your child may be in a school program or recreational or leisure activity, there's going to be a wide range of experience and knowledge of those people facilitating those programs. And so I would encourage you to be proactive in letting the team know, the leaders of whatever program you're in know what your approach is to social boundaries and consent and things like that, and really ask them to come sort of on board with you. The things you're going to ask them to do would be good for the whole program. So it's a great conversation to have, but I would encourage you to be proactive, given that there's probably a wide range of sort of skills, ability, and focus. I'm guessing we're right at the end of time or over, but we'll try to catch you and see if we can answer your question after the fact, if that's okay. Okay.
Well, thank you so much, Dr. Nowinski and Dr. Stanley. What a wonderful presentation. And hopefully you'll be able to catch them at the break if you have additional questions. Well, we're now in for another real treat. We have Nicole Simon next. She's going to present on behavioral therapy. Can it help children with Williams syndrome? Nicole is the senior behavioral consultant at the Lurie Center for Autism. She's a board certified behavior analyst with more than 25 years experience in the field of ABA and challenging behavior. In her almost 10 years at the Lurie Center, she has provided behavioral support and consultations to many children and adults with Williams syndrome. And we're so fortunate to have her as part of our team. Welcome, Nicole.
Okay. Welcome, everyone. I know that a few are still coming in from the other presentation. Seems like they were very different presentations walking into this one at the end. But again, I'm Nicole Simon, and I'm going to be talking today about behavioral therapy and can it help children with Williams syndrome. We'll talk a little bit about common behavioral challenges in children with Williams syndrome. And then because my background is in applied behavior analysis, ABA, that's going to be the focus today, both what is it and how it can help you and your child. And we'll discuss some resources at the end. So to start, some common behavioral challenges with Williams syndrome, and this is from our clinical experience. So you may be experiencing different things at home, but transitions and meltdowns surrounding transitions, either to a non-preferred activity that could be for older children, something like homework, for younger children, something like toothbrushing, moving away from something that is preferred, like a toy or an iPad. Following multi-step routines can be challenging, a morning routine or evening routine. Co-sleeping with a parent That can be a challenge. Frequent phone calls to parents, stealing or hoarding preferred items, lip gloss, food, etc., lying due to fear of disappointing a parent. So you might notice a theme as I go through these. And while you have a wonderful and close relationship with your child, no doubt, there can be some challenges that come out of that, that relationship. Which brings me to the power of you, all of you as parents, and this idea that behavior influences behavior, okay? So your response to a behavior can make things better or can make things worse. Your child's frustration and anxiety can lead to your frustration and anxiety, which in turn can make the situation for your child difficult, and it can be difficult to calm them down. And so to change your child's behavior, you may need to change your own behavior, okay? And so we want to think about and this is hard, but how we can be intentional with our body language, with our voice tone to try to project calm and confidence. Really difficult when our child is throwing a tantrum and having difficulty. It's hard to do. We might think about those verbal interactions and how even if your child is quite talkative and has a lot of verbal language, in a moment of frustration, they may struggle to communicate. They may struggle to say what is wrong and what might help. We might want to talk a lot during that moment. We might want to excessively reassure them when they're feeling anxious. These are things that might not be so helpful. But it is extremely hard to do these things, to remain calm in the face of challenging behavior, which is why it is so important to think about self-care. Okay, I can't talk to parents without talking about this. I'm sorry, I have to get it into any talk because I think it is so, so important. And I'm not talking about lavish, spa days every Friday, which would be amazing, or vacations. I'm talking about what you do in your everyday world, every day, every week, every month to take care of yourselves. And I'm just giving some examples from, I do workshops with families all the time. Some favorites, Epsom salt baths. That was a whole topic of conversation in a previous talk. This idea of double tasking has come up quite a bit. So many of you might feel like you're an Uber driver with your child, driving them all to all sorts of places. Maybe during that car ride, you listen to your favorite radio station. You listen to the podcast that you like, right? Double task there. Asking for help, sleep. This came up in the talk next door, right? Sleep is so hard to come by. So maybe your self-care is just focusing on, can I get sleep when my child is sleeping? But if you can commit to a few minutes every day, 10 minutes a day, a couple times a week, that is going to help you be in a place where your behavior and your reactions are going to support your child. So think about this, self-care as a necessity, not as a luxury. All right, so is this a reinforcer? Here is the scenario. Let's say I said to all of you parents, audience, you have been doing a fabulous job in this talk so far. You're attentive. You are giving me great eye contact. You're taking excellent notes. And so therefore, I'm going to pass out a piece of chocolate cake to each and every one of you, right? Woo! Okay, this talk is great. This actually is not going to happen. But if I were to say that, would this be a reinforcer? The answer is, you can answer it in your own head. Actually, it would be a reward. What would make it a reinforcer is if moving forward in the future, if you were more likely to now pay attention, give me good eye contact, take good notes, right? All of those things, that's what makes it a reinforcer. It's about what happens in the future after that behavior occurs, okay? That's what the principles of behavior are all about. And here are a couple of examples. Reinforcement comes after behavior, makes the behavior more likely to occur. Punishment comes after the behavior, makes the behavior less likely to occur. In that same example of the piece of chocolate cake, if I were to deliver that cake to you and you have a chocolate allergy or you hate chocolate, whatever it might be, and now you're like, huh, this talk is terrible, I'm not paying attention, I'm closing my notebook, I'm not giving eye contact anymore, your behavior decreases, that chocolate cake served as a punisher, okay? So it's really just about the operation, what happens after behavior, and then what happens in the future. And I wanna just make a comment about reinforcement. when reinforcers are used in behavioral programs, oftentimes initially they can be contrived. They could be stickers, they could be tokens, they could be toys, things like that. Our goal is to move toward natural reinforcement, things that are naturally occurring in our world, in the environment. And because I have a lot of parents who say to me, why can't my child just do it because they're supposed to, or because, that sort of thing. The reality is we all work for reinforcement, okay? If you have a job outside the house, you're working to get paid so you can pay for all sorts of other reinforcers, right? Maybe it's rest, maybe it's that glass of wine, maybe it's socialization, but these are some of the principles of behavior that come into play when we think about how I like to define ABA, or applied behavior analysis. I intentionally like to think about it broadly, and this definition applying behavioral principles like reinforcement in real world settings. This could be at home or in schools or out in the world at restaurants, for example, to address socially important issues. And this is going to be a whole host of things. That could be communication, that could be taking a shower, that could be socializing with peers, you name it, and it'll vary over time. Certainly, applied behavior analysis is known as an evidence-based treatment for autism, and we know it to be effective across the lifespan. So children and adults, we know that it can improve behavior, but also can be helpful with teaching skills. But what a lot of people don't realize is that this science actually is applied well beyond autism. In fact, it's used in transportation industry, it's used in health services, health sciences rather. It's used in environmental sciences and things like climate change and recycling, right? And so when you start thinking about it broadly like that, you realize how widely it can be applied. So the overview of ABA, I like to think about as the what, the why, and the how, okay? So starting with the what, this is what does that behavior look like? And with that requires observation of the behavior along with data collection, okay? ABA, we like to look at data. So what does that behavior look like? When does it occur? Let's take some data to give us that information. Once we understand what that behavior looks like, we want to understand why it occurs. Why does that behavior occur? Functional behavior assessment is the tool that we use to start to answer that question and help us to understand why it occurs and what the triggers might be. That's very, very important within ABA. Once we understand why, then we get to the how. What is that behavior plan going to look like? How are we going to use those behavioral principles to come up with interventions to change that behavior, to generalize it across people, across different places and settings, and to maintain it over time? And how do we teach new skills? Ideally, ABA programs are developed and monitored by a board certified behavior analyst. That would be somebody like me. And the people who are carrying out the program ideally are trained in ABA. But again, you see that image there. Data collection is very important in this ABA process to help us understand about the behavior and learn about it. All right, so one of the tools that we have to understand and learn about behavior is called the antecedent behavior consequence, the ABC. This is a temporal sequence. The antecedent just comes before the B, which is the behavior, and the consequence comes after, all right? And we use this to help us to understand the relationship of behavior and its function. So here's my next scenario for all of you. Let's say that you came into this conference center this afternoon, not having had your cup of coffee, really needing caffeine, and you walk in and you see a vending machine, okay? Woo, score. There's your antecedent. All right, seeing that vending machine. You want that Coke. So you take out your money, you put the money in the machine, you press the Coke button. That's your behavior. What's the consequence? Your Coke drops and you're now able to drink your soda and have your caffeine, right? That's how it should go. But let's say on this fine afternoon that you've come into this conference center, you've put your money, you've seen the machine, you put your money in, you press the button for Coke, and that Coke does not drop. What do you do? I can see Terry in the back. You shake the machine, right? You shake the machine. Why do you shake the machine? Is it because you're mad? Maybe, but okay, for those of you who said yes, if you go to CVS and there's no Coke, are you shaking the clerk and swiping no, you're not doing that. Why do you shake the machine? You shake the machine because you have experienced or seen in the past that shaking that machine loosens the Coke or the bag of chips and it drops and you get that reinforcer, right? You have experienced that in the past. That is why you shake the machine. Maybe there's a little anger built in there as well. Let's fast forward a month from now. You come to this conference center for another conference. You also forgot to have your coffee that day. You see that vending machine again and you're like, oh, okay, you put your money in and you press the button and your Coke doesn't fall, okay? You might shake that machine again. You're not going to feel too good about that. Twice in a row this has happened. You come a third time, 3 months from now, and you see that machine. First of all, hopefully you will have remembered to drink your coffee, but you see that machine and you put your, well, actually, let me ask you, are you going to put your money in it again 3 times? No, why not? Because you learned, right? What happened after your behavior the last 2 times has now taught you that this machine doesn't work, right? So it has impacted what you are going to do in the future. Last part to this scenario, you're flying out of Logan this weekend, you see a vending machine, you're going to use that vending machine? Yeah, probably. You might be a little tentative, but you probably will because that's the power of being able to discriminate between this faulty machine and this other one that likely works. So you're understanding what I'm saying here. This is a real life scenario. There are countless examples of how these behavioral principles apply to all of us, impact our behavior, and how we learn. Okay, here are some examples that might be a little bit more relevant to you and to your children. Parent tells Jenny to clean her room. Jenny cries in tantrums. No. Mom puts her in timeout and begins to clean her room for her, right? Oh, that kind of worked out well. Teacher's at another student's desk assisting with work. Tim starts throwing items across the room. Teacher comes over, tells him to stop, gives him some attention, right? Okay. Peer takes Sarah's doll away from her. Sarah hits the peer and the peer drops the doll. Sarah picks it up and begins playing with it again. So in all of these examples, these negative behaviors are getting that child what they want. So do you think they're more likely to occur in the future? Yeah, right. And it's not because anybody's teaching them, it's just what's happening after their behavior. And so why does behavior occur? Behavior is functional. We all engage in patterns of behavior that work for us in some way. Some of these are adaptive, they're good. Some of them aren't so good, they're maladaptive. A lot of times they're communicative in nature, which is why it's so important to prioritize enhancing those communication skills, especially during those toughest moments of frustration and anxiety, right? That's when it can be really, really hard to communicate. And often these behaviors are learned, right? Again, that's not blaming any parents. You're not actively teaching your child this. It's just over time, those ABCs, what happens after the behavior can shape it. The good news is behaviors that can be learned can be changed, right? We just need to make some adjustments in how we're interacting with them. The functional behavior assessment, as I mentioned earlier, this is how we get to the why. It's a process of gathering information. It results in a hypothesis about the function of the behavior. It includes a few different elements: a record review, interviews with parents and teachers, observation and data collection and assessment. And this is an important point because one of the questions coming out of today, well, how do I get ABA? An FBA should be completed as part of an initial evaluation through a school evaluation, for example, or whenever a behavior plan is needed. So in the event that, let's say a school is telling you that we have created a behavior plan, you can request that FBA. By the way, there's a law that requires this, Individuals with Disabilities Education Act, but you can request that ABA. That could be one route to potentially accessing ABA services once you've asked for that FBA. So again, why does behavior occur? I like to keep things simple. Two major categories: to get something you want or to get away from something that you don't want. And within those broad categories, there are subcategories: attention, tangible, escape, sensory. The same behavior can have different functions, okay? So here's an example. I'm not going to go through this whole chart. You can substitute any behavior in there for hitting, but we'll use hitting as an example. But as you read through that, you see 6 different descriptions of hitting behavior, okay? Just a couple examples: hitting when parents aren't paying attention, hitting when told to brush teeth or do something that they don't want to do. And each of those equates to a different function, okay? So the question for all of you is, do you think that all of these descriptions with these different functions would lead to the same intervention? No, okay? And that's important. That's why it's so important to understand why a behavior occurs, because that is going to then impact the treatment and the intervention. So take a moment to reflect, all of you, parents, okay? And hopefully you've been doing that already. Think about the behaviors that your child engages in, and think about, how is your child's behavior working for your child? That's the first question. And the second one is, how is your response working for you? Okay, so let's go back to that an iPad example again, or put in anything that the child really likes. They're playing with their iPad or their favorite toy. You tell them that time is up and you go to take it away. They have the big meltdown. No, I don't want you to take it away. You say, okay, you can have 10 more minutes. You can have 15 more minutes, right? Did that work for your child? It works for your child, absolutely. Does it work for you? Yes, it works for you. Your child just got 10 more minutes. You just got the end of a tantrum and the end of the screaming, and you got 10 or 15 more minutes to do something different, right? It works for everybody. This is how these behaviors get reinforced, right? And this is what we want to be thinking about, to think about, how can we make some changes so the negative behaviors aren't working for our child anymore. So then we get to the treatment once we understand why the behavior is occurring, and we want to think about treating underlying medical causes. We want to think about, once we've done that, what that behavioral intervention might look like, that it should be based on the principles of ABA, that it should be both proactive and reactive. And we want to think also potentially if medication would be helpful. That's not going to be the focus of my talk, but I include it in there because that might be something that you talk to your medical provider about. But to talk a little bit about the medical piece of this, okay, it is incredibly important to assess and address the possible underlying medical causes of behavior, all right? So this is Xavier, who's a 6-year-old boy, and he is in a small classroom, separate classroom in a public school setting, okay? His special education teacher is out for the week, and he's with a paraprofessional. He doesn't talk much, and he's pretty quiet. He's doing his work one day, on that Monday, and he starts hitting at and tugging at his ear, okay? Clearly seems to be something going on. And the paraprofessional says, Xavier, what's wrong, buddy? Come here, and gives him a big hug and says, come over here and take a break, pulls him away from the work. Go sit on the beanbag. Here's a lollipop. And she's very concerned about him. And, you know, he's doing this. And this happens a couple more times that day. And, you know, when he's fussing and kind of hitting and tugging, Xavier, are you okay? And she gives him another hug and brings him away from work. This goes on for a couple of days. This behavior. And on the third day, she says, oh, maybe I should bring him to the nurse. And so she brings him to the nurse, and the nurse says, oh my gosh, why are you just telling me this now? Calls the parent. You should probably take Xavier to his pediatrician. The parent does that. Xavier gets evaluated by the pediatrician. What do you think he has? Yes, very good. You're still paying attention. I should get you that chocolate cake. Yes, he has an ear infection. So the pediatrician prescribes antibiotics. Xavier takes them. A few days later, the ear infection goes away. Does this behavior stop?
No.
Okay, I hearing a lot of no's. The answer is maybe, right? Why did that behavior start? What was the root cause? What was the driving force? It was the ear infection, right? We have now cleared up the ear infection. Okay, so theoretically, that should stop. But what else happened, right? Lots of things. A nice exaggerated example. He got attention, he got hugs, he got to not do work, he got lollipops, right? All of that reinforced the behavior as well, okay? And so this is an example that, yeah, maybe the behavior stops, maybe it continues for a little bit, who knows? But for those of you who have kids who are dealing with chronic medical issues, reflux, constipation, all of the things that you might be seeing, you need to think about this interplay, right? We have to be cognizant that any behavioral issue could have a medical cause. We have to assess, we have to treat that, but we also have to remember that that manifestation of that behavior is going to come into contact with the environment. It could be reinforced and then it could take on a life of its own. So it is complicated. How might this apply to behaviors driven by anxiety? Same type of thing, right? So when I go through the sort of the what and the why, and you might think, well, no, but all of my child's behaviors are anxiety based. Again, those same manifestations of behavior are coming into contact with the environment. So we have to think about how do we interact with them and what are we teaching the child in terms of managing that anxiety. Okay. So in terms of the ABA approach and Williams syndrome, again, this is in my experience. In my experience, what has been most helpful is to focus on a proactive antecedent-based approach, right? What are the supports that need to be put in place before the behavior occurs? Also, I find that it's helpful to use visuals. That could be things like social stories or schedules. And absolutely supporting the parent in terms of helping parents to recognize their role in changing behavior can be really helpful. These are some generic sample proactive strategies. Addressing the basics, can't stress this enough. Dietary habits or eating, sleeping, and exercise, right? We got to start there. If you have a child who's not sleeping, first of all, probably then the whole house isn't sleeping and their behavior is going to be bad. Okay, so is yours. So we got to start there. We have to address that first, and we need to look at that as something that's primary. Having your child in a positive environment certainly can be extremely helpful. Making sure that their day is structured with meaningful activities. I think any of you with older children who experience COVID with your child, right? You experience having their schedules just ripped out from under them. That was extremely difficult, okay? Structured, meaningful activities. Using visuals, again, that could help to prepare them for, something that's scary, a change. It could just be part of their daily schedule and what they have to help guide them through their day. Using tools like timers, audible timers, visual timers. Certainly, choice making can be extremely helpful as well. And these are a couple examples when I talked at the beginning of some of the COVID things we see. I wanted to wrap up with, how might we think about this using more of an antecedent approach? So meltdowns around homework, for those of you who have children who aren't going to be, thinking about homework for a really long time, substitute anything there, right? It could be meltdowns around toothbrushing. Minimize the triggers. Number one, does that activity need to happen? How do we pick our battles, right? So homework is a favorite one here because do they need to have the homework? Because the teacher says, because I think that they need to, right? Can we just get rid of it altogether? If that's your biggest source of stress, maybe we get rid of it altogether. Maybe your child needs a homework accommodation through their IEP. Maybe the work is too difficult. We need it to be easier. Maybe we need a shorter duration. How do we optimize that schedule? Thinking about when is the best time to do the homework, again, or whatever activity is that you want to substitute there. Is our child well fed and rested, right? What happens right before and right after the homework? Here's a little tip. If you're going to have them do their favorite activity like screen time and follow it with homework, okay, that's going to be tough on both ends. You're going to have the hard time getting them away from the screen and a hard time getting them to their homework, okay? So maybe we don't pick the most rewarding activity to put before the least favorite activity. What happens right after? Well, don't have chores come after homework, right? Because that's another bad thing. We need to have something that's motivating. So that's why I like this example on the visual here, where you have a healthy snack that comes before homework, and after homework, play outside or relax. Offering choices, including non-critical choices. Do you want to do your homework now or in 5 minutes? Do you want to do it at the table or on the couch, right? These are things that can be really, really helpful. And you see there too, visuals, as I've mentioned, can certainly be helpful as well. Another example, stealing behavior, and we'll use the soda stealing since that's sort of a theme for today. Allowing access to the soda or whatever that item is within reason, right? Not free access, not all the time, but you want to make it clear when and how that soda is available. And maybe you create a visual that you post and review, okay? So if you are going to withhold completely, it's going to get stolen, right? Somehow, somewhere. So if that's the goal and the reinforcer, how do we make it available and how do we make it clear when it's available? How do we minimize the triggers? In the case of stealing, oftentimes the trigger is the presence of that item without adult supervision. Okay, so that could be in the home, which is why if there are items that get stolen in the home, you might need to think about locks. This picture example is of a soda in a trunk of a car, because and I again worked with many families who say it doesn't matter where I put it, they find the key. But we need to be creative there as far as how we're storing that item at home. And in stores, if your child is old enough to be able to go into stores independently, we have to think about that. Do they need supervision? Is this something that they can manage? And if they are going in, what are our checks in place? How do we check before? How do we check after? Functional communication training, replacing a behavior with a functionally equivalent communicative response. That's a mouthful. All that basically means is replace the behavior you don't want to see with a behavior that you do want to see that gets the same outcome. So the replacement for stealing an item is requesting it, right? Asking for it. That doesn't mean that then they get it all the time, but that's going to be a much more powerful way to get that item versus just taking it. And then lastly, considering daily check-in meetings. I'm a big proponent of this. Again, it's a proactive approach that if we know this is an active concern, how do we check in with our child to review the expectations? How do we make sure that that is as consistent as possible? I will tell you specifically with soda stealing and my experience with Williams syndrome, it is not a malicious behavior. The intent, it's often opportunistic or impulsive. And so because of that, we again have to think about what can support that individual. If we use the traditional ABA maybe approach of or punishment of, well, you stole the soda, now you're not going to get it for a week, right? That's going to lead to feelings of shame. It's going to lead to feelings of guilt. And it's going to be really then more challenging as far as where do we go from there. Let's beat that behavior right before it happens, and let's be proactive and reinforce the behaviors that we want to see, okay? And then lastly, co-sleeping with a parent. I want to talk about this. We talked about the functions in terms of, behavior working for a child and a behavior working for a parent. This is a classic one, right? Why do people co-sleep ultimately? Because everybody gets sleep, which is so important. We're sleeping together and you're happy and I'm happy. We all sleep and then we have a better day, right? That's where it starts, but then it continues. And then your child's 10 and 12 and older and we're all still sleeping together. And that can be challenging, okay? So we want to prepare our child for the change. Again, that could be a social story. First of all, you got to be ready as a family, as parents. You need to all be on the same page and ready to do this, especially if it's been happening for a long time. Those of you who are parents of younger children, be careful about starting this because talk to the parents of older children, it can be really hard to change. But prepare your child for the change. Explain the rationale. You're a big kid now. Big kids sleep in their own bed. Whatever's going to make sense for them. Systematically fading co-sleeping. We don't just sort of go cold turkey. There's all different ways to systematically fade. Maybe you're fully sleeping together. Maybe you're then sharing the bed while they're falling asleep. Then maybe you're sitting in a chair in their room next to their bed. right next to the door, right outside the door, right? So there can be a process of fading your presence. Offering a functional equivalent replacement activity, there's no replacement for a parent being in the bed, but something like maybe hugging a body pillow or a stuffed animal. Maybe the stuffed animal has mom's shirt on it, so it smells like mom. Whatever it is, like that could be something to try. But ultimately, teaching new behaviors, routines, or skills is going to be something that we're going to want to focus on. Maybe that snuggle time with the parent happens before the bedtime routine on the couch, not in the bed when it's time for bed. Maybe we introduce an okay to wake clock. That's a clock that has a color. Let's say it's red that's on, and we teach our child when you see the red color that you stay in bed. When it turns green, you can come out of bed, right? Maybe we talk about coping strategies to manage their anxiety, the separation anxiety from the parent. But I'll tell you this, if you think that the task is over once you've gotten them to bed successfully without you, know that at 2 o'clock in the morning, they're coming back to find you, right? So you have to still be on top of what do you do at that point? What is your strategy? And how are you going to maintain that, knowing that if you give up because it's been three days and it would just be easier if we all slept together, we're sort of right back to where we started. So this is not an easy one, but it is a common one. And there's all sorts of behavioral strategies that can be tried. So to answer the question of this talk, behavioral therapy, can it help children with Williams syndrome? I'm going to say yes as an answer to that question based on what we talked about today. But there is a but, and the but is that it can be challenging to access the services. So I just want to be clear about that, and many of you might know this already. Many insurance companies will not cover ABA with a Williams syndrome diagnosis. I'm sure some of you have tried to get this. A couple of things that you might consider trying is requesting a letter of medical necessity for ABA from your Williams syndrome provider or from a pediatrician. That potentially could help. Obviously, all insurance companies, as well as even across states, they're really different with how they think about this. Parents may self-pay for services that can get expensive, so that's difficult. As I mentioned a little bit earlier, you might try to seek ABA support through the IEP process or through schools, starting with that FBA. Some parents I know do try to seek an autism diagnosis to gain access to services, and just want to make a note that a traditional ABA approach or a therapist or behaviorist without experience with Williams syndrome may not be as helpful as somebody with experience, but that's certainly another tactic that folks try. A couple of resources, again, most of these resources are in the autism world because that's where they mostly exist, but these are places where you can get some more information and sort of reinforce some of the concepts that we talked about today. We offer behavior and safety workshops at the Lurie Center. And so I think that in your folders, you have some descriptions of those. The last one is a new offering that we have, which is a monthly drop-in Ask a Behaviorist group. And so a small group, so that could be something where you get some questions answered there. And we also offer behavioral consultation services, outpatient, that typically involves collaborating with the school team and the home team, as well as if you're nearby, potentially homeschool or community observations. So that's what I have for you today, and hopefully I'm within my time frame. But thank you, everybody. Do we have time for questions?
Thank you so much, Nicole. What a fantastic talk. I hope that you all see the brochures for how to attend some of those workshops or the consultation services with Nicole, and hopefully she'll stick around for the break. So if you have a question or two, to get her then. I see Dr. Pober coming to the stage.
Do you want to explain the Lurie Center as part of MGB?
Oh, yes. Let me talk a little bit about the Lurie Center. So the Lurie Center for Autism is a multidisciplinary neurodevelopmental center based in Lexington, Massachusetts. It's part of the Mass General Brigham healthcare system. We work with both children and adults with a wide variety of different neurodevelopmental disorders. So autism, of course, but also other syndromes such as Williams syndrome, Down syndrome, Angelman syndrome. And today we're so fortunate to have a number of our staff members here today to share their knowledge and expertise, including Dr. Nowinski, who you already heard from this morning, Nicole Simon, Dr. Jill Pineda will be speaking later today as well. All right, so with that, I'd like to introduce our next speaker. Our next speaker is Sarah Gidding. She's the Interim Executive Director for the Williams Syndrome Association. Thank you so much, Sarah, for coming all the way from Florida to be here with us today. And thank you for telling us a little bit more about the WSA.
All right. First of all, thank you all so much for coming. It's so exciting to see so many of you here. I'm going to probably skip a little bit through here because you heard about me. I have a 22-year-old son with Williams syndrome, and that's kind of how I got involved with the organization quite a while ago. And now I'm helping make all the things happen. If you haven't heard about the WSA, it's just important for us that you walk away today knowing that there's that resource in your head. So in your folders, there's a brochure about the WSA, has the website on there. So we just want to make sure that you know that we're here for you. We really are focusing on 3 key areas: connections, and I heard in the younger family session this morning, you know, the importance of those connections. So connections, resources, and research. I was started back in 1982. Really, the goal here is to support all of you on your journey and your individuals with Williams syndrome as well. So some examples of connections, and I want to just make sure, because I know I'm between you and break right now and everybody's getting antsy. I just want you to walk away knowing that we've got some great resources for support. There are some support groups that are out there. I've got a slide on that. We'll talk about that briefly. But one of the positives that came out of COVID is the ability to connect virtually. So everybody kind of has had to use Zoom for things. So there's some really powerful stuff happening on Zoom. We've got virtual programs for adults with Williams syndrome, summer camp. I saw some camp families here today, some social connection events. There are walks. There's one happening tomorrow. Hopefully we see everybody out there tomorrow. Buddy programs, conferences, some partnerships with other organizations. And then, you know, when we get out there and try to meet all of you. Some resources that we offer, and I'm just going to fly through these, but they're on the website. Our goal is if you need something, we help find that for you. So you can call in. If we don't have the answer, we're going to get you connected with somebody who does have that answer. We send out monthly newsletters. We've got the website. We have a podcast happening. We just had the national convention in Phoenix in July. The next one, and there's a slide for that to save the date, is in Buffalo. So hopefully we see all of your faces in Buffalo in 2026. And it was really emphasized in the session this morning for the younger parents how important trying to get to those things are. You have all of the Williams syndrome experts right there at your fingertips, and they stop and talk to you when they're walking through the halls and will answer your questions. It's a really incredible group of resources there. Family support volunteers are there. So when you reach out and you have a new diagnosis in your area, there's somebody that you can call and talk to, meet face-to-face to be able to connect with someone else. We have specialty clinics, which we talked about briefly this morning on the website. If you search clinic, you can find one, see if there's one in an area near you. Guidelines to follow for new diagnoses that was being spoken about this morning. There are healthcare guidelines throughout the age span. Educational support, an updated educational profile that Robin, who some of you will hear from later, just helped publish with a number of other specialists, therapist consultations, transition services, tools throughout the lifespan, as I mentioned. And we're working really on developing more and more partnerships with other organizations so we don't have to be the expert in all things for you. Research is that third tenet, and our goal is really to fund that high impact research in different areas that impact the entire Williams syndrome community, to invest in early career researchers. So we continue to cultivate that pipeline as our current experts get ready to retire. We want to replace those. We have the largest collaborative registry for Williams syndrome. There's a brochure for that in your your folder. If you haven't taken the time to be part of that registry, make sure that you take a few minutes to do that. And then the clinics that we mentioned actually all meet together as a group. So that was mentioned this morning too. You know, it's not just the specialists here in Boston that know each other. They know the specialists in all of the other clinics, and they meet monthly to discuss things that are going on, to create best practices, to determine the questions that should be asked during your appointments, the things that we should be looking into. So that's a really powerful collaborative that's happening as well. I mentioned the Family Support Network, so I just want to make sure that you all know that on the website, you can go on the main page, there's a button that says Connections. You can find someone locally in your area. Their email is listed there. If you can't find somebody, call in or email in. Our contact information will be on the last slide. We can get you hooked up with somebody in your area. If you want to be one of those resources for people, let us know. The more resources we have, the better. We have lots of support groups. They're all listed here. We're adding more consistently. They meet monthly. They're hosted by other parents that are passionate about that topic. We also have some hosted by medical experts. So very quickly, for this group, there's a group for parents of children with Williams syndrome who are 4 and under. So I know that group really speaks to some of the people that we were talking about in the new diagnosis group. Children with feeding issues, parents, caregivers of teens, tweens, dual diagnosis of Williams syndrome and autism, Williams syndrome and anxiety, transition from high school to adulthood, parents and caregivers of someone whose only child has Williams syndrome, parents who are exploring one of the Think College programs, adults with Williams syndrome and anxiety, adults with Williams syndrome with challenging behaviors and moods, and then adult siblings, grandparents. I know we have some grandparents in the room. There's a group for you as well. Soon to launch a stepdad's dad-like caregivers group, a grief support group, and we're going to start, this started as a sewing group, but you can come on, do your crafts, knit, sew, whatever you'd like to do, talk about that, and talk about whatever's going on in your Williams syndrome world. Those are the groups now. If you see a group that you think we need that's not up there, reach out and we'll get that started too. This just mentions our partnership here with Mass General, the Lurie Center, just such powerful resources you have. So I know that you all know that taking advantage of coming here, but it's an incredible partnership, and it really is the only program that provides that comprehensive care for individuals with Williams syndrome of all ages. Here's the convention save the date that I told you about, July 7th through 11th, 2026 in Buffalo, Niagara. We're calling it the International Convention because we're going to be partnering with the Canadian Association for Williams Syndrome. In that, the goal is to have a walk that either goes across one of the bridges to Canada or at the park right by Niagara Falls. So one of the days we'll be going to the falls and doing a big collaborative event with everyone too. So we'll be bringing the Canadian Association, Canadian members down. So it's hopefully within driving distance for lots of you. So make sure that's on your calendars as well. And I just wanted to give this to you. If you're not involved with the WSA, the first thing is make sure you join. If you go to williams-syndrome.org/join, sign up. If you think you did a while ago and you can't remember if you did, or if you signed up and you're not getting newsletters or emails from us, go back on, sign up again, and we'll make sure that you're getting everything. We send out a newsletter monthly towards about the 25th of the month. So that if you're not seeing that, make sure you join again. Follow us on social media. If you're on social media, participate in the support groups. If you don't see one that would speak to you, let us know, and we can see about getting that going. If you want to get more involved as a volunteer, you can become a Family Support Network volunteer to support other families, host a social event, participate in those local events. If you don't see a local event, it's very likely that there's no one there volunteering to host it. We help you with that. It's easy. So if you want to see something happening in your area, reach out. Quickly, participate in a local walk, participate in Awareness Month, join us at summer camp. All of you have kids that could join us at summer camp, and attend convention in 2026. There's the contact information. I'll be out there at break, and thank you all so much.
Thank you, Sarah. I've heard an alternate name for, is it Craft and Gab? Stitch and Bitch. So on that note, That, please, everyone, go next door. There's a small refreshment break, and then we will start back in here at 3 o'clock. Thank you.
I just made the assumption.
My sister just got married. Yeah. Oh my God. Yeah.
Oh, do you want to show me that while I,
Maybe you can ask.
yeah, yep. Hello again. Can- Um, we are eager to move on to our next session. It gives me enormous pleasure to introduce two people. Dr. Robin Tom is a child and adolescent psychiatrist, and as I mentioned earlier, is co-director of the MGH Williams Syndrome program. She sees patients with Williams syndrome of all ages for emotional and behavioral health care, with a focus on anxiety since 2019. She's a graduate of Harvard Medical School, the Harvard Longwood Psychiatry Residency Program, and the it's got a long name, but the MGH and affiliated hospitals Child and Adolescent Psychiatry Fellowship Program. And it's a pleasure to work with her on a regular basis. Zooming in is Dr. Karen Levine, who's a psychologist and part-time lecturer in psychiatry at Harvard Medical School. And she and I co-started the children's Williams syndrome program together back in 1987. So I'm now going to turn it over to Dr. Tom.
Thank you very much. And hi, Karen. I saw you there for a minute. But anyway, so I'm going to get things started. I'll talk for about 15 minutes, and then I'll turn things over to Dr. Levine, and then we'll hopefully have about 10 minutes or so at the end for questions. So here are my disclosures, and I'm going to try and cover two things today. So first, I'm going to give a broad overview of anxiety, and what I want you to be able to do at the end of today's session is to be able to decide, is your child anxious, and is it something that we ought to do anything about? So that's goal number one. And then goal number two is a very special topic to me. I'm going to present for the first time results from a trial that we did starting about 3 years ago, where we tested buspirone, a medication for treating anxiety in children and adults with Williams syndrome. And it's so special to be here today to present those data, first because there are people and families in this room who participated in the trial, so thank you. And also because this work was so generously funded by the WSA. So with that, what is anxiety? Well, anxiety is a feeling like any other feeling, but kids, and especially kids with anxiety, may not say, "Mom, I'm anxious." They may say, "I'm feeling scared, I'm nervous, I'm worried, I'm afraid." These are other words that they may say. Of course, some kids won't say I'm scared, nervous, or anxious, but anxiety may actually show up in their bodies. And anxiety can actually affect almost any part of the body, but I think of it as kind of being a midline issue. So when you go top to toes, I think of, in the head, people can feel kind of lightheaded. They can feel like they have a frog in their throat. They can feel like their mouth is dry. Their heart can beat really fast, and that can be really confusing when the kid already has cardiac symptoms, or maybe has had some medical trauma earlier on in life. We hear about GI symptoms sometimes getting a lot worse when people are anxious, feeling like they need to throw up, or maybe use the bathroom really urgently. And then I also see a lot of leg shaking when kids with Williams syndrome are anxious. And the last thing that I always ask to check when I see a kid with Williams syndrome in my clinic is I ask to see their hands, because kids who are anxious often have very short fingernails, and their parents say, "Oh, we never cut them." Or they have bleeding cuticles. And so picking and biting are pretty common signs of anxiety. Of course, anxiety also affects how we think and how we see the world. So we could be experiencing the same thing, but depending on how we think about the situation, that really affects our anxiety level. So if I go outside and I see a dog and I say, "Oh, what a cute dog, I want to play with that dog," then I probably feel fine. But if I think, "Oh, that's a really scary dog, I think it's going to bite me," then probably feel pretty anxious. In addition to affecting the body and how we think, this is a really key point, especially for the age range that we're talking about today. Anxiety can really affect what we do or how we behave. So all of these words on the screen here, some of them may sound familiar to you or resonate. Behaviors like refusing, picking, rubbing, rocking, checking, pacing, questioning, bolting, tantrums. These can all be signs of anxiety, and it makes sense because if something is making a kid scared, of course they're going to do whatever it takes to get out of the situation. I've summarized all these different words into behaviors that lead to avoidance, so the thing that makes them afraid. Increased repetitive behaviors. So that's where you see the rocking and the picking and leg jiggling, and then reassurance seeking. So, Mom, when are we going to go on a plane? We're not going on a plane, right? We're not going to go see Grandma this Christmas. So, all of us feel anxious from time to time. That's a normal human experience. But how do we draw the line between a feeling and a disorder? Well, in psychiatry, we use this big purple book called the DSM-5, and it outlines 5 different types of anxiety disorders. There's specific phobia. That's when people are very afraid of one specific thing. The most common specific phobias we see in Williams syndrome are generally things related to sounds. So sirens, storms, fireworks, dogs barking, those sorts of things. Generalized anxiety disorder is when the person is worrying a lot about things that happen in their everyday lives and they can't turn off the worry. Sometimes they worry so much that they also get physical symptoms, like they feel really tired or worn out or have a lot of muscle tension. Separation anxiety is when a person has a lot of fear that when they're apart from their loved one, that something bad may happen. And funnily enough, I actually don't see this so much in my youngsters. I actually see it more in my adults with Williams syndrome. So something to keep in mind as your kids grow up. Social anxiety disorder, that's when a person has a lot of anxiety in social situations. They're worrying, what if I make a mistake? What if I say something wrong? What if people don't like me? And I think sometimes we under-recognize this one in Williams syndrome because oftentimes people with Williams syndrome are so friendly and bubbly and energetic and love being with people. But just because you love being with people doesn't mean that sometimes you have a lot of sometimes really bad fears about what they're thinking of you. And then the last one is panic disorder, and that's when people get panic attacks. So these are out of the blue attacks where you have a huge sensation of dread. You have a bunch of different physical symptoms like sweating, heart racing, feeling tingly, feeling the world's not real. It kind of goes up really fast and then usually peters off in 5 to 20 minutes. And people with panic disorder get panic attacks over and over. So these are the different 5 kind of flavors of anxiety in the general population. People with Williams syndrome did not read the DSM-5, so they also manifest anxiety in a few other different ways, which I'll share in a moment. But the key for you to remember as parents is if you're thinking about, is anxiety something that I ought to do something about? You want to be thinking, is it persistent? Like, how often does it happen? Is it there a lot of the time in many different places and areas in the child's life? And is it making life hard? Is it making it so that the kid's not able to do the things that they want to do? Is it making activities within the family challenging or difficult? So a few years back, I did my first study in Williams syndrome. And the question we wanted to answer is, what does anxiety look like in kids and adults with Williams syndrome, and how bad is it? So in this graph, every blue dot is a person with Williams syndrome. And on the left, on the bottom scale there, the low numbers means low anxiety. And as you move to the right, that means higher and higher anxiety. And the red line is at a score of 10. That score is the minimum score that you need to enroll in a pediatric anxiety trial. And as you can see, most people in this study, and some of them were getting treatment and some of them were getting medication, a lot of people with Williams syndrome have what we consider clinically significant anxiety to the level that we need to do something about it, but not everyone. So some other facts about anxiety that we learned in this study were that we could kind of group anxiety into 3 different themes. As I mentioned already, sensory-based anxieties are really common. The other common theme of anxiety we heard over and over again from families was anticipatory anxiety. So that's worrying about things that are coming up, things that haven't even happened yet. And you know what? They can be things that are good and things that are bad. So I hear from a lot of families that my child's birthday month is the hardest month because they're so excited about it, but they're always asking, what are we going to do for my birthday? Is this going to go to plan? What if it rains? And they're constantly reassurance seeking to be sure that everything happens the way that they want it to. And then the third flavor of anxiety that we saw, and this was actually more so in our older patients, so more like teenagers and adults, that we started to hear more and more fears of social disapproval and letting people down. One thing that commonly underlies a lot of these themes is an intolerance of uncertainty, meaning that one kind of root cause of anxiety that we've discovered in our research is that when something is not 110% certain, that can be a cause of anxiety in people with Williams syndrome. And I wanted to share some direct quotes from parents who participated in this study, sharing about how anxiety affected their child's quality of life. We heard that anxiety kept one child from experiencing new things. Another person with anxiety actually had to have a G-tube because she was so anxious about feeding. Other parents said that anxiety really got in the way of making friends because she would get upset and the other peers would have a hard time with that. Another parent told me that, I think my child's anxiety started when she was a baby. We always thought she could walk, but she was too nervous to it. So that probably delayed it by about a year. And then another theme that kept coming up was that learning could really be impacted by worrying, because if you're always worrying when the next thunderstorm might be, it'd be kind of hard to pay attention in math class. All right, so that's my overview of anxiety. And now let's turn to learning about what we learned from the buspirone trial that I know many of you are familiar with. So just to step back and give some background information, buspirone is a drug that we've had around for a long time. It was approved by the Food and Drug Administration back in the 1970s, actually, for generalized anxiety disorder in adults. The reason why it's not kind of a household name like Prozac or Paxil is because it's a medication that actually doesn't work that well in the general population. But over years of experience, we noticed that buspirone seemed to work pretty darn well in people with Williams syndrome. The other thing that was really attractive about this medicine is that it really doesn't have side effects relevant to people with Williams syndrome. So of course, we're always worried about cardiac health. We're often worried about changes in appetite or changes in weight. Buspirone doesn't have any of these issues. So the first thing we did was we actually started this study some time ago, but once we had collected about 24 people in our clinic who had been treated with buspirone just in the clinic, we wanted to know how many of them had a good experience with it. And about 67% of people who were treated with buspirone just under clinical conditions had a pretty good response to it. The other good news was that only one person in that 24 had to stop buspirone because of a side effect. So pretty well tolerated and helped most people. So once we were noticing this in clinic, the next step in medical research is to do things a little bit more systematically, to really test out, does this work when we titrate it, when we go up on the dose in a more systematic way, in the same way for everybody. We really wanted to learn in more detail, like, are there side effects of the medication? So we're meeting with people very regularly, taking them through side effect checklists. And so this is what we did. This was a study that was funded by the WSA, and we were very fortunate to have 20 people with Williams syndrome participate in the study. We had people from all over the country actually come and participate in this study. They came to the Lurie Center in Lexington. They met with me, made sure that they had anxiety at a level that was reasonable to start medication for. Reviewed their medical history to make sure that there wasn't anything unsafe about starting buspirone, and everybody in the study got a prescription for buspirone. We increased the dose over the first 12 weeks of the study if it was clinically appropriate to do so. Some kids got better at like week 4, so we didn't push the dose. 18 of the 20 people finished the whole trial, meaning that they took the medicine, they met with me every 2 weeks for 4 months. And of the 18 people who finished, 18 out of 18, everyone had significant benefit. The medication was also tolerated pretty well. The most common side effect was GI. We saw kind of a range of different things, like maybe a little bit of queasiness. Some people had stomach aches. Some people felt a little bit nauseous, but actually nobody had to stop the medicine because of any side effect. So very reassuring. So with that, I'd like to thank all the patients and families who come to MGH and entrust us with their care, and in particular, those who participated in research. Thank you very much. And Dr. Levine, over to you.
Can we ask a quick question? Can you specify what the doses were that you were using within your trial?
Yeah, so it was a flexible dose. So everybody started with 2.5 milligrams in the morning, and then we went up every 2 weeks if there was still room for improvement with the anxiety. There was a wide dose range that we ended up with. I think the smallest dose that we ended up on was 5 milligrams for some people, and went as high as 30 milligrams per day for others. Wide dose range, and some of the littlest kids ended up on the highest doses, and vice versa.
Thank you.
But over to you, Dr. Levine. Thank you.
Okay, David, let me know when I can be seen or heard.
Go ahead.
Excuse me?
Yeah, go ahead. Yeah, go ahead.
Oh, okay. Can you all hear me? See me? Great. I'm so sorry not to be there with you today. I'm sure it would be much more fun. Robin, what a terrific study. I mean, you almost never see a study of anything where you get 100% positive response. That's just phenomenal, and for such an important problem. Oh, I can see you. Hi. Okay, I'm almost there. I didn't get any snacks, but okay. So I'm just going to very quickly talk about treating phobias. And sometimes, even when medicine helps anxiety, which is absolutely phenomenal, some of the phobias are continue because they're kind of a learned, almost like a learned habit, a learned response. And so we still need to undo some of them. I don't know if any of you had that experience with your kids or adults. It's much easier to undo and learn new responses when your baseline anxiety is much lower. So nothing wrong with meds and treatment, or try treatment and then meds, or some combination thereof. Okay, this is going to be a quick run through. So if you don't get it all, that makes sense. We'll tell you other places you can get it. Let me just make sure David has a message for me. Full screen slides. I'd rather show the slides this way, if that's okay with you. Can you see them? Yeah, was that a yes?
Yeah.
Okay, good. When I go to full screen, I can't mess with them as much. Okay, this study also was funded in part by a grant from the Williams Syndrome, several grants from the Williams Syndrome Association. And Bonnie Klein-Tasman, a psychologist, research psychologist who researches anxiety treatments at University of Wisconsin-Milwaukee, got a multi-year grant. And I'm the clinical advisor or consultant to the grant. And Brianna Young also got a grant and did her dissertation on this treatment approach. Okay. So as Robin was talking about, one form of anxiety that's extremely common in children with Williams syndrome, adults too, but especially children, more than half of children with Williams syndrome show fears or phobias that are to a degree that's problematic for them. I imagine some of these look familiar. Yeah, okay. Haircut, shots, fire drills, fire alarms, key fobs, thunderstorms, escalators, fireworks, toilet flushes, clapping, vacuum cleaners, hand dryers. And there are lots more, coffee grinders, there are lots more. And that fear spreads. I mean, so if you're afraid of a hand dryer, you know, don't go near one. But the problem is it ripples, as Robin was talking about, to anticipatory anxiety. You know, what if, let's say you're afraid of thunderstorms, what if there's a cloud in the sky? What if it's going to thunder? What, you know, and it can go to checking the weather. Let's check. Oh, there's a cloud on the weather report. Maybe it's going to thunder. And I'm sure those of you who have anxious kids with phobias know that phenomena very well. So it can really take over a lot of time and disrupt a lot of well-being. Fortunately, it's the emotional part of the experience that's usually what's overwhelming for the child. The actual physical sensation of these things is usually quite tolerable after infancy, after the child's a little bit older. But it's the emotional part. They've developed these associations that, oh, this is going to overwhelm me and I can't handle it. And of course, sounds really startle, probably more for kids with Williams syndrome. Shots really hurt. But generally, the physical discomforts are mild enough to be tolerable for the child, especially as they mature. And I say fortunately, because we're much better at treating emotional distress than we are at sensory sensitivity. An emotion is your brain's creation of what your bodily sensations mean in relation to what's going on around you. So it's the sense you make of that sensation. So you hear the beginning of a noise, or someone says, oh, it's gonna thunder, and you get overwhelmed. It's because your mind says that's gonna be terribly scary, more than I can handle. The more relaxed you are, the more happy engaged in this green circle, the less something will bother you, a sensory thing. And that's true for all of us. If you're relaxed and laughing with the person giving you your COVID shot or whatever, you're going to be a lot less upset by it than if you're super stressed out, think you might have walked into a sketchy pharmacy or something, and then it's probably really going to hurt. So it's a lot easier for kids to approach the things they're scared of if they're in a relaxed, happy, engaged state. And we've found in the research studies, I work with kids with autism, and of course, some kids have Williams syndrome and autism, but kids with Williams syndrome so often are so ready to be engaged in a happy state that almost makes it particularly easy to get them into that state as you're doing the gradual exposure, as you're treating the phobias. Ideally, the child could magically, for instance, have a shot when they're in a happy, engaged state, and then they could develop a new impression of it. But that's hard to do. So what treatment does that? In this treatment model, we help the child have new, pleasurable, non-scary experiences with what they're afraid of. And then through that, they develop new associations. And we construct playful ways of doing this gradual exposure. So gradual exposure to what you're afraid of is a tried and true behavioral approach. I don't know if Nicole talked about it earlier, but there's tons of data that gradual exposure helps us overcome what we're afraid of. But the problem with doing gradual exposure in a more traditional, sort of old school way is that it can induce a lot of distress. As you're doing a lot of even the small exposures, kids can be unhappy before they get happy again. But if you incorporate lots of happy playfulness and make it super fun for them, incorporate their interests, what they like, and a happy, playful interaction, they can tolerate more and more exposure in a way that doesn't induce distress. So here's a child with Williams syndrome. Let's make sure you can all hear it. And this is a child from our research study. So this was in Milwaukee and Bonnie's lab where we could video. And he started off a bunch of fears, but we were working on hand dryers. He was very afraid. So you'll see me showing him the unplugged hand dryer on the floor, and you can see he's afraid. This will be our video test too.
No, I think it is.
Can you see and hear it? Hopefully that was
But it's
yes.
not plugged in, because here's the plug. It's not, are you scared? We can cover it back up. What is that? Is that a hand dryer?
Yeah.
Is it real?
Yeah.
Oh my goodness, what does that say? Feel the air. Bee, bee. Oh man.
So you can see he's a teeny bit interested, but he's still pretty anxious.
Yeah, would that be a little
So then we look at the bottom of it, talk about how it works. I show him a little video of how it works.
Yeah, like the motor is. Should we look for a video of the motor? I bet we can find one.
So he's a little interested in that, but then he's not really loosening up. So then I have him and his mom leave the room, and I make a video I put one of his figures that he brought to the clinic in a toy school bus. I put it on the floor and I shoot it on the floor with the hand dryer. So I have the hand dryer blow his character across the room in a school bus, and he thinks that's pretty fun.
I'm gonna put the bus there. Did you see the bus go? I put your guy in the bus. Was he sitting in it?
What's that?
I put your guy in the bus. Woo.
So you can see as we're doing this fun play, he's getting gradual exposure to the sound of the hand dryer.
He was going like that. Oh, watch this with the blanket.
And then I put the blanket over it and show him that.
Isn't that funny?
I want to do that.
Okay, we can do
So then already he says, I want to do it again. He's like, this is fun. A whole different association.
funny, okay. Okay, let's see, we turn it on. Put the guy here with the ready. That's too funny. We spread the blanket. Should I do the blanket again?
That's fun.
That's so funny. Ready?
You can see it's as if the sound doesn't bother him at all at this point.
How about some tissues? Ready? This went far.
I'll put this
try it. Close your eyes, though.
Yeah, I was afraid it would fly into his face.
How about the blanket? Try the blanket. Okay, ready? You're getting pretty brave. Okay, put your face down. Did you feel it?
So then we made a field trip to the university bathroom that had a hand dryer. And we didn't need him to use it, but he was so into it.
This one's loud.
It's a little loud, yeah. It's a little kind of loud. It's gonna be a little scary. Oh, should I try it?
Yeah. Are you scared? Are you sure? You're ready. Get my go.
So we did some play like that with the scarf.
Oh, you did it!
Now it's your turn.
Okay, is it gonna eat this one? Is it gonna be loud?
No.
It'll be okay.
I'm gonna do the blue one.
Okay, I'll do the white one, you do the blue one.
I did it.
You wanna try the white one? Okay, just do this end.
And then he, on his own, he decided to use it.
There you go. That was a funny one.
That was a funny one. Yeah, let's go for it. And architect, go.
I did it.
That's so
It was awesome, and it wasn't unusual in not every kid. It wasn't as good as Robin's data where every kid had a complete, a good response, but most of the kids had really quite remarkable responses quite quickly. If your child, so this isn't a how-to, obviously, in 20 minutes, but if your child is struggling with a phobia, know there is help and hope out there. And then we've published some of the studies so far. Okay.
Well, thanks so much, Karen.
Sure. Thank you. Thank you for making this Zoom work too. I hope
I
you
think
were
we
able to
have-
get a little feel for it.
I think we have some time for questions now. I see a question at the front.
What age? Obviously, anxiety manifests in different ways. You have a 3-year-old. You don't know if he's anxious or just he's being 3. What ages do you like for us adults who are not as experienced about the economy? What are we looking for at different ages? When should we be like? What's the trigger? Like, okay, this is how we from an anxiety perspective, especially for Williams.
So to repeat the question, which is a great question, especially for younger children, how do we know if they're anxious and if their anxiety is at a level where we ought to be doing something about that? Karen, do you want to take that one?
Well, just in terms of phobias, if they're really avoiding things that you think would be fun for them, you know, if they're, I don't know, running away when they see a dog or screaming when they sing a happy birthday song, if there's something that's really, you know, getting in the way for them, you don't have to sort of decide if it's pathological or not. You can just say, would it make sense to help them with this issue? Would it make sense to make some headway rather than just avoid it? Our tendency is always just to avoid the thing that makes the kids scared because we don't want them to be in distress. So I think the moral is maybe you can do some little work with it, sing really quietly, play it on the video really quietly, or do, you know. So I guess if you notice your child being terrified about a lot of things that are kind of interfering with their life, that would be what I would consider in terms of phobias. Robin, I don't know if you would address that in terms of medication or leave it.
Yeah, yeah. I don't generally treat very young children with medication across the board for Williams or otherwise. The reason being is because not many studies have been done to establish the safety of any medication in children really that young. And then just broadly speaking, the younger the child, the less effective the medication, generally speaking in psychiatry, and also the higher risk of side effects. So for a 3-year-old, I'd really be thinking about different types of behavioral approaches. Oh, and this family had quietly asked me a question earlier at the table. In my study, the age range was 5 to 65. I do treat 5-year-olds with medication on occasion, including buspirone, and it has worked for children that young. I think the youngest child that enrolled in my study was 7 when they started. So that Dr. Levine can hear, if you don't mind using the mic, that would be great.
Is this on? Yeah. I feel kind of convinced about buspirone from your study, and my child's on guanfacine. And what are my steps, or what is my first step to make a choice to put him on buspirone instead? And what does that look like?
Yeah, so I think the first step would be to discuss with your child's prescriber. Our data on buspirone should be published in a matter of months. So it'll be helpful to have that. But actually the retrospective data, so the data showing what happened in our clinic patients, that paper is already available. So that could be something you share with your prescriber. I'm guessing that part of your question is, does my child need to be on guanfacine and buspirone? Should we take him or her off of it first? To answer that question, I think you'd want to really think with your provider, is the guanfacine doing anything? And if so, sometimes I like to add the second medicine before taking the first one away, because if you take it away and it's doing more than you thought, then your child could be in a not great place for a while you're ramping up the buspirone.
Our son is 11, and I really appreciated the example of the hand dryer, but for him, it's not a fear. He is actively seeking them out. And so is that the same anxiety presenting differently, or is that maybe a different issue that we would look into?
Shall I answer that, Robin?
Yeah, yes, please.
I mean, I often say yesterday's phobia is tomorrow's obsession, passion, or obsession. 100%. I mean, you know, for most of us, there's some truth in that. Like often, you know, newscasters may have had speech therapy or stutters as kids, that kind of thing. You often sort of become passionate about the thing that you overcome. I don't know if he was afraid of it at one point, but kids with Williams syndrome often have sort of passions to the point of sometimes obsessions, and that's a whole other talk for another day, but it's not unrelated to this at all. You're picking up on a really good point that you're raising.
I would say that if your child only wants to interact with hand dryers in a very prescribed, like very rule-bound way, that may indicate there's anxiety, more probably along like the OCD spectrum.
Right, right. And sometimes that's a way of coping with a primary fear. You sort of give it you sort of have it in the bag. You're in control of it. If you seek it out, you play the YouTube videos, then you stop playing the YouTube videos. It's such an interesting flip side of the same coin sometimes.
So I was wondering how often you see anxiety come out as anger, because I'm starting to wonder if that's what we're seeing more of. My son gets especially angry at the cat, and I think it has to do with smells that are causing anxiety, because he loves the cat, but he's almost fearful of the smell of like the cat food and things like that. And so he gets mad at the cat.
Certainly.
It's also puberty too, right? Like, how do you, I was thinking when they were talking about puberty, how do you know if it's just the normal emotional, you know what I mean? Like, how do you know? Because I'm thinking of your child's age.
Yep.
I guess for the way I think of it is, you don't so much have to know, is it Williams? Is it neurotypical? Is it adolescence? Is it anxiety? I mean, you basically want to treat it. You want him not to feel angry at the cat, whatever it is. So you want to treat it by figuring out what can develop his comfort level with the cat. Is it putting the smelly things in another room, a little separate? I don't know if that's feasible, but is there a way to make the things that bother him about the cat more tolerable to him? Because it sounds stressful for the family and stressful for him, because it sounds like he loves the cat and yet gets this anger. And anger and anxiety can be intertwined often.
I just feel the need to tell Dr. Levine that in the room here, I think because you're not here, like there were so many times that we all wanted to cheer about the hand dryer. And I just because we get that so much, I could feel it from so many people. So just the work that you guys are doing is so important and we appreciate it. We know it's a rare syndrome and it's I'm so thankful that people are paying attention in these ways.
Thanks for sharing that, because that's one thing I hate about Zoom. You can't feel the vibe. So thanks for sharing them. I know when Bonnie and I do this work, we're just it's heartwarming each time to see these little kids sort of conquer their fears and they celebrate, even though they do it joyfully, they kind of know I did this thing that I used to be scared of, and it's very moving work.
I have a question about the anticipation anxiety, like when they're anticipating something, if it's a positive thing that makes them happy, should we be taking steps if they're getting too overly excited? Or is that just part of Williams syndrome? Because sometimes it can derail a whole day because they're so excited for seeing a specific person or to get to play with markers after something that they can't focus on what they're doing.
You want me to take that, Robin, or you want to take that?
Sure. Why don't you give it a go, and then if I have anything to add, I'll
Okay.
chime in.
Yeah, again, if it's a problem, if it, like you say, if it's ruining a whole day, that's a problem. So then you want to sort of put parameters around it, oh, we'll talk about, when Michael's coming over, let's talk about it and let's draw a picture of it or write about it, write down the list of it, and then let's put it on the shelf. And then let's go get ice cream and we're gonna go to the beach and here's the 4 other things we're gonna do. And then we'll take it off the shelf when we get home and talk about it some more. So you want to kind of structure it, which is very hard to do. And then when they raise it again, you don't want to be too off-putting, but you want to say, oh, do you remember what we did with that? Remember when we're going to do that again? So you don't want to eliminate it completely, but you just want to chip away at it, curb it, and then do super fun things that can keep their anxiety down between now and then. It's extremely common in Williams syndrome, and it's common in kids with anxiety in general. Those repetitive questions about, because excitement raises your arousal just like anxiety does, and both of them cause that anticipatory jitters kind of.
Yeah, I completely agree, Karen. And then that makes me think of something that Nicole raised earlier this morning with the visual schedule and moving it, kind of showing where we are in the day and how many more things are happening before the excited event. One thing that I hear a lot about from parents of younger children with anxiety is that they are so excited / anxious about something that's really good that's coming up, that by the time the really good thing happens, they're not able to enjoy it. So if you're seeing your child in that state, then I think it's worth considering treating the anxiety.
Definitely. I mean, it's always a question of how much is this interfering with their well-being, with our well-being as a family? And are there other things we can do about it, or would medication make it all much more manageable? And then you still probably need to do the other things. You still may need to shelve it and do the visual schedule, but you're likely to have more success if their baseline anxiety is down.
About approaches to treating anxiety, using therapy in older children or adults. I imagine that this play-based therapy is more useful for younger kids.
Yeah, I'll just repeat that question. So the question is, are there therapeutic approaches for addressing anxiety in older children or adults? So I didn't have time to speak about it today, but actually Dr. Pineda, who's here in the back, and you'll hear from her later this afternoon. She and I, a few years ago, modified a CBT program specifically for adults with Williams syndrome. So we were able to take core components of CBT, which is cognitive behavioral therapy, and make it suitable for adults with Williams syndrome. And we found it really quite helpful for those who participated. There's a paper that's been published about that experience as well, and we're happy to share that with everyone.
One thing that's
Well-
great about, oh,
That was me, Karen. Barbara, go ahead.
one thing great about CBT is, you know, if you don't have access to Robin or the clinic, there are a lot of therapists who know CBT, and then if they're open enough to learning the spins and variations on it that are particularly helpful for kids and adults with Williams syndrome, you'll be able to find people who can help. Okay.
Well, thank you both. So before I forget, there was a question about session 5A and B, the IEP, navigating the IEP. Dr. Pineda informs me is definitely appropriate up to age 6 okay, 6, 8, 7, 6, 8, okay. So now we're actually very excited about our next session. We added this to the program based on input from families who said, you know, we'd like to hear from some adults with Williams syndrome. We have some amazing adults with Williams syndrome who live around here. So Dr. Christopher McDougall, a psychiatrist who is the director of the Lurie Center for Autism and the Nancy Lurie Marks Professor of Psychiatry at Harvard Medical School, is going to moderate. And we have 4 adults. There are steps up front and there's a ramp in the back. Ben Moncaba, there's a chair for you. And let's see, Tim Deneen, there's a chair for you. You're going to get mic'd up. Becky Kleinman and Stephanie Carone. So take it away. Oh, and why don't you go ahead, I'll catch up. They've been here for many hours, which is terrific, and they are happy to chat with you afterwards.
Do your thing. Turn it on, leave it on.
Okay.
Just hold it or
Pocket or?
pocket.
As a
All right.
Hello, Dr. McDougall.
Hi.
Nice to see you.
You did. You did. Hi, Becky.
Oh, hi. Tony Deneen. Nice to meet you. Nice to meet you too.
It's on. It's off.
You will put you right here.
Okay. Yeah. Good.
Sorry.
Yeah. There we go.
Maybe just.
Okay, thank you.
Tim. Tim. Okay.
Where's the hand? Oh, so can I give this? Or do you give it? Okay.
How's everybody doing today?
Okay.
Good.
It's wonderful to be on
So
stage here with you all.
thanks to Dr. Poper and Dr. Tom and their team for putting together this conference and allowing me to participate. Thanks to the Williams Syndrome Association leadership for being here and whoever's sponsoring the conference. Thanks to all of you for coming probably from far away to attend such an important event. We should give Dr. Poper and Dr. Tom a round of applause, please. So we have the most important session yet, right?
Yes, yes, yes.
So
Of course.
I know two of you. Becky, tell everybody where you live.
Right now I live in Norwood, but pretty soon I'm moving back to Arlington.
Move where?
Moving to Arlington.
Oh, nice. And Stephanie, where do you live?
I live in Manchester, New Hampshire.
New Hampshire. How about you, Tim?
Hamilton, Massachusetts.
I know where you live. Where do you live?
South Hadley.
South Hadley,
Yes.
Massachusetts? Okay.
Yes.
Oh, wow.
And let's tell everybody, we'll go right down the line. What do you do kind of day to day? Monday through Friday, what kind of things?
It depends on the day. Sometimes I work or I volunteer or I go to my friend's house. It depends on the day. My work schedule changes week to week.
Can you all hear her? Okay. And Stephanie, what do you do Monday through Friday?
Monday, usually I would volunteer at the cat shelter that I work at. Thursdays, I would work like every other Thursday, 3 times a month, but I used to volunteer at a food pantry and help people that need food that don't get it, and usually go to my sister's house sometimes, or they come over, so that's nice.
How do I do this? Just like this? Me and my sister live together. So she has a dog. I do trash, recycling, normal day chores. Go to Hampton quite a bit. My best friend is the chief of police in Hampton, New Hampshire. So I go and visit him whenever we can get together, and I got 3 nieces and a nephew. 2 live local, 2 don't. And have friends that come by once in a while and say hi and check on me, which is good. My friend Glenn I grew up in Groveland, Mass. So gentleman lives in Merrimack, a friend of mine lives in Merrimack. He was the foreman for the Groveland Water Department where I grew up. And I get to see him once in a while, and and the little dog, we cuddle, I take her for a walk because we have a nice long road. It's probably as long as this here. So I walk her all the time when weather permitting. So other than that, hang out at home mostly.
You're a busy person.
Yes, I am.
Yeah. Thank you. And Ben, how about you? What kind of things do you do during the week?
Well, I have a very enjoyable life, as a lot of you know. So sometimes I would go to taverns, sing with Moose and Michael. I do that. That's a lot of fun, which I enjoy. And I also work. Let's see. So I work with Clouding for Kids, which is an organization that does parades. I love doing that. And it's a joy to do that whenever I can. And I work with Angeles. She's my caregiver. And so we work on chores and different stuff. And I get to have a lot of fun in my free time. So it's a lot of fun when I get to do that too. What about your work? Oh yeah, my work. Thank you. Thank you. My work is I work with a man named Ed. He's a wonderful man, and I love his wife very much. And what we do is we sing I will go to different nursing homes and I sing for residents to make their day better.
That's cool.
Yeah, it's awesome.
Yep, very, very good. I like that. Pretty slick.
And it makes their day better because when I have a bad day, I want someone to come and cheer me up, so I cheer them up the same way.
There you go. That's right. I agree.
So that's the serious part of your lives, like your work week and everything like that. And I know each of you has a fun side too.
Yeah,
And things that you enjoy doing, right?
yes.
Becky, what's something that you, like a hobby or,
I like playing hidden object games on the computer or paint by number games.
tell us a little bit more about that.
I just like going on the computer a lot. I'll watch videos and then go do computer games or workbook stuff and then go back to playing computer games.
Great.
And I like hanging out with friends too.
Yeah. How about you, Stephanie?
Well, I have tattoos. I really enjoy getting tattoos. I actually have a tattoo of my cat that passed away on my arm, so I love going to the beach. Love going to the beach. Love going to the animal shelter and playing with the cats and everything. It's a lot of fun, and I spend a lot of time with my sister and her family.
Do you like cats better than dogs?
Yes,
I do too. I don't have any room for dogs.
I'm sorry, but if I say this, the dogs are a pain in the ass.
Sorry. Sometimes I agree with you.
I don't have a dog, but I can agree they can be a pain sometimes.
I've had a cat every day of my life.
Yeah.
Yeah, you can't beat a cat, but dogs, as you described them quite well.
Yes.
Right, what do you think, Tim, about cats and dogs?
I personally, I get along with both, but sometimes I love our dog, but sometimes I agree with, you don't argue with a cat, you argue with a dog more than a cat.
Right, that's for sure.
Because a cat can't talk back to you like a dog can.
Yeah, that's right. That's right.
And
then at least if it's a dog you're not familiar with, at least you know a cat, you're more liable not to get bit.
For sure.
Well, my sister has a puppy and she bites every time, and it doesn't matter what time of day or night or whatever.
Oh my God, yeah.
She is a pain in the neck.
Yeah.
But I really enjoy both because I'm an animal lover myself, so I enjoy both no matter what. I still love cats and dogs no matter what. If they're my pal, I love them. If not, I still do.
There you go.
I mean, I do like dogs better than cats, but cats don't bark back at you. Do.
Oh yeah, she is.
Well, Stephanie, you brought up a topic that everyone has a lot of interest in. Cats and dogs, you know.
Yeah, I
and
agree.
The audience seems to really be into this too. So like, okay, raise your hand if you're mainly a cat fan. I don't know.
Ah, there we
The
go.
rest of you just haven't experienced cats yet then. The rest of you like both or neither one or dog, raise your hand if you're a dog fan. Oh, there's.
God.
Well, you must be, I'm not a very social person, which is why I like cats. But you must be very social, those of you that like dogs. That's what I would.
Yeah.
Huh?
Yeah, I mean, your dog, if you're having a bad day and everything goes downhill, the dog's right next to you.
Yeah.
A cat is too, but more a dog than a
I
cat.
see. That's a benefit of a dog, is they're right there with you.
I enjoy having fun too. So what I do for fun is I do my clowning work, my drumming work, and I enjoy every minute of it.
There you go.
So that's, I know you a little bit, right?
Yeah.
I love music too. Music.
Well, that's
is
what I
a
want to talk
big
about
thing.
now.
Oh, man, no.
Ben, tell us about some of the groups and singers that are at the top of your list.
Okay, first of all, I'm a Swiftie, of course. No problem there. I'm also a Beach Boys fanatic.
Oh, yeah.
There you go, right up my alley.
Me too.
And also, I'm from Detroit originally, so I like the Motown music.
There you go. Motown, you can't go wrong with that.
And so I like all kinds of music, and I love going to the conventions and dancing with my friends and having a great time.
Tim, tell us about some of your music interests.
Well, the Beach Boys,
Beach Boys, yeah.
Meatloaf, AC/DC.
AC/DC, right.
Oh, boy.
Kenny Rogers, a lot of the older groups, because I was born in 1971, so all the big popular groups were just starting out when I was growing up.
Yeah.
So, and I have been to concerts at the Hampton Casino Ballroom more than once, and those are a lot of fun. My friend got us really, I mean, the seats were here, and the stage was probably, I don't know, not that far from us. And I forget who, I think it was Trish Yearwood I saw that night. And, and a bunch of big name groups, George Thorogood, all the old groups, because I'm, in 1970s, 80s.
How about you, Stephanie?
I love Michael Jackson. I love.
Yes, there you go.
Where's Michael Jackson from originally? Do you know what state? It's a tricky question. Indiana.
Oh.
We won't go through having you name his the other 4 members of the Jackson 5 by first name. But if you're curious, it's Jackie, Jermaine, Tito, and Marlon. They had a younger brother named Randy and sisters, as you know, Janet and Latoya. Okay.
I love Janet and Michael. Both, they're my 2 favorites.
You can't beat it.
No.
And I love Billie Eilish.
Oh, wow. That's a more popular modern singer.
Yeah.
She has Tourette's, and
I didn't know that.
Yeah, she has that, and I have it also.
You do?
I do.
Wow.
And she's a great person. She does a lot for people, so that's really nice.
And one of my favorite concert, wait a minute.
How about you, Becky?
I like country music.
Country. Go.
Oh, yeah.
Give us a couple.
Rascal Flats,
Yep. Heard of them?
Jelly Roll. What is that his last name?
Jelly Roll.
And
Yeah.
I don't know what other ones. I like a lot of them, though.
And here's a more serious topic, okay?
Okay.
We know that anxiety, many people with Williams syndrome and everybody else has anxiety.
Of course.
We've got a lot of parents out here of younger kids, right?
Yes.
And they want to learn from you.
Okay.
What's something you worry about? Name one thing you tend to worry about.
What do I worry about?
If there is anything.
I worry about too many things. Like, what if my mom's gonna be okay? Or no, like what's gonna happen at my house? Cause it's been crazy. Like, is the staff gonna show up? Are they not? Are they gonna do the job they're supposed to? Because they don't at all. That's why I'm moving out.
And when you feel nervous or worried, what do you do to try to calm down or deal
Call
with it?
my mom and my brother, talk to them.
Yeah. Talk to people.
Yeah.
What do you worry about, Stephanie? One thing.
Oh, boy. I just worry about like my family and stuff like that. I have severe anxiety and like badly. It's been very bad lately, so I've just been dealing with so many things, doctor's appointments, and feeling like let down and like nobody wants to be around me. And just really hard things to deal with. And for the first time in months, I cried on Monday after my doctor's appointment because I was so overwhelmed.
And what do you do when you're feeling that way that's helpful?
I try to like think of the beach or just talk to somebody or just try to like relax, but it's been very bad. Like I don't sleep well either, so the sleeping is the worst. Like if I don't get enough sleep, I am.
Thoughts that kind of run through your mind when you're trying to fall asleep and things.
Yeah, a lot of the time.
Yeah. How about you, Tim? Something you worry about?
I had a sick mother last year and it didn't go good. She died last year and I had to call the paramedics quite a few times.
Jeez.
And where I used to live, the police were always good to me. They still are to this day. And one night, my mom, I'm in bed, door open. On 1, 2 in the morning, I forget what time it was exactly. My door opens and I go, uh-oh. I wasn't sure if it was a firefighter or a police officer. I didn't know it. And my mom had fell and I get up the following morning and I find out that I go down and I go, Mom, how's things today? Not good. I lift up the blanket. She had broken her foot. And I go, then unfortunately went downhill. After that, and the fire guys are great. They're nice guys. They're all good guys. I swear. And, and they know me well enough now, and they go, hey, darn well, you need a hand with something, you just give us a holler. And I go, thanks, guys, I appreciate that. And
who's someone you can talk to when you're feeling stressed out?
My sister, she's right there.
Who's that?
Melissa, that's Melissa right there.
Okay.
And my other friend Tracy. And she keeps me sane. She really, really does. We may have a bad day once in a while, but most of the time we get along really well. We have fun together. We get into mischief together. And that's what is, what? People say money's good, but if you haven't got your health, you haven't got a single thing. You really don't.
True.
Sure.
And I met Dr. Powert last year or at the beginning of this year, I forget which. And she's top notch. She's a very nice lady.
Yes, she is.
And she's one of, and I thank my siblings too. I'm one of 4. I'm the oldest, she's the second oldest, and we have one younger, they're both younger than us. So I have a brother, Michael, and a sister, Jen, and they're good kids. They really are. And, I had people around me all the time when my mom was sick. And if I had to get somebody in a hurry, they'd be there because all the guys would always stop by and check on me.
Yeah. You've got a lot of people that care about you. Let's see what something Ben worries about.
I know, for me, I think what gives me anxiety and what gives me, let's see. Well, I'm very nervous about hospitals and all of that, so that hasn't stopped.
Yeah, I don't like hospitals
That will
either.
never go away. And it's the anxiety that I have, and it's really hard. Like I keep asking over and over questions because I have anxiety. It's really hard for me to stop asking those questions, but I do thank people who have helped me through that. And it's really nice when people can help you and ask you questions who are there for you. And I think we have the best doctors in the world. That's what I think.
I agree with that. Children's Hospital is the best hospital in the country, as far as I'm concerned.
MGHs too. MGHs too.
So remember, you guys are the experts in the room, and we've got these parents out here of these younger people with Williams syndrome, and they want to learn from you. So what's something, Becky, you would say to these parents of younger kids about what it's like to be an adult, something that would help them out in thinking about the future of their
I have an idea.
child?
That some days it's easier than others. Our brains go through a lot each day. That everything's gonna be okay, even if at a point, even if it doesn't seem like it will be, it will be.
You're generally a happy person? Good. What advice would you give, Stephanie?
Oh, sorry. And we're always usually very happy.
I would say, to love your kids before anything happens to them, because you never know. You could wake up one day fine and then the next, they pass away, or like a grandparent or something like that. Like kids with Williams syndrome are usually happy, but when things happen to people that you love, like someone committing suicide or someone dying of Alzheimer's and dementia, you just gotta make sure that you take care of them and love them every day.
Live every day to the
Yeah.
fullest.
Yes, exactly.
Don't take
yep.
things for granted.
Nope.
Nope.
I agree.
What's something you'd pass on to these parents about help their younger kids?
It's a really kind of I just, as she said, just hold on to them, hang on to them and love them in the way they are. Cause you can fix some of the problem, but not the whole thing. And you sit there and I didn't know I had it until I was like 2 years old. And I go, and people will say, and you gotta hang on to these little guys because they're precious, I look at my sisters and my brother's kids, they're growing up on me and I go, you blink your eyes and they're gonna be grown up and so quick, and you blink your eyes and you go, where'd that all go?
That's
And
for
for
sure.
me, I want to say to your lovely parents that people with Williams syndrome are very gifted in everything that they do. They
Oh,
make your
yes.
day happy and they care for you and they love you. And I hope that they grow up to be whatever they want to be, whether it's a musician or a clown, or if they want to do whatever they want to do someday. I hope that you can make their dreams come true because they deserve it.
That's right. I agree, really,
Say something. Yes, they might get upset, mad, or angry at you, but don't worry, they don't stay like that long.
Yeah.
Should we take a couple questions from the audience? Why don't we take make sure we can hear you now when you may be, what do you need, a microphone or not? Okay. I'll be like Johnny Carson or something.
Prompt my daughter to say what your work is and say a little about where you are living now and where you're moving to and the difference.
I work at Wegmans. I'm a cashier. I work at the one in Westwood, but I'll probably be moving to the Burlington store.
Oh,
Oh, and I live in Norwood right now, but I'm moving back to Arlington in a few weeks, but not living with my mom,
Arlington.
but closer to where she is. With myself, my own house, my own apartment for the first time.
wow.
Very good. Am I supposed to clap for that? Very good.
Wow. That's great.
I want to piggyback off the question you asked about parents. You guys have in your life heard from scientists and doctors and advocates and advisors and parents, your parents and other people's parents. What would you tell another WS child? What is your message to them, to, looking back at your own life and the struggles you may have had, or the good, the bad, the ugly? What would you tell them?
Don't dress the way you want to dress. Because not like for younger kids, for some of them, I'll look like at conventions and stuff. I'm like, you really wearing that? Like, no, like you're gonna give the guys the wrong ideas.
And so what I have to say is just imagine how exciting their lives can be when they have a dream and they live the dream. It's very exciting thing, because my dream was when I was a kid, I wanted to become the most greatest clown. I got to do that. So that was a dream and I lived it. And that was really fun. So if your kid has a dream that they want to do, make sure you can make that happen, because they'll be the happiest person in the world if it ever happens to them.
Yeah, that's very true, because
yeah,
I've had a lot of family members help me with a lot of things. And when I was 18 years old, I was going for an open heart surgery, and my sister surprised me. We were going to see wrestling and I had no idea. She said, "Oh, my friend's going to a wrestling match. Who would you think she want to see?" And I said, "The Rock." And we went to the wrestling and I got behind the scenes tickets to see The Rock, and
awesome.
Oh my God, it was amazing. And he's massively tall.
Yes, he is. He's a big boy.
And
He is. Yeah.
And I'm like short compared to him.
Hey, and that's true, because them guys are like, those guys are humongous. And one time my uncle got us wrestling tickets to Portsmouth High School.
Oh,
So,
wow.
of course, one of my all-time favorite wrestlers was there, Andre the Giant.
Oh, wow.
And he walked right by us, right? Right. And I think he looks big in the ring, right? You see these guys, and I go, wait a minute, they're huge. And then another time, me and a friend of mine went to the WWF in Boston, so it was Ric Flair against Hulk Hogan. So Ric Flair gets disqualified. Hulk Hogan grabs him and his manager and does one of these numbers. Bob smacks their heads together. And I go, ouch. I wouldn't want that.
But speaking of legends of people who they met, actually, I got to meet the great legends, America's Band, the Beach Boys, and that was the most awesome experience. I would never forget that day.
Really? Wow.
And
yeah, very good.
They were just really nice guys, and they invited me up on stage, and that was the most greatest day. And people came down from the stage and they said that when I was coming down from the stage, people loved it. They thought it was the coolest thing they ever seen, so.
Yeah,
Oh
that's
my
pretty,
God, that's amazing.
that's pretty cool, man. That's pretty cool.
Yeah,
Ben, we know Brian Wilson's a musical genius.
yes, he is.
Yeah, I like,
Kudos to him for making that great music.
yes, there you
Kudos to
go.
him, yes.
So we're gonna have to wrap it up, but I think I really appreciate you guys taking the time to help us learn. You did a great job. You're wonderful people. And what do you all think?
Yeah, thank you, guys, thank you.
Thank you, thank you.
Yeah, thank you.
All right.
So let's turn it back over to Dr. Tom here. Okay,
Yeah, let's do it.
we got to keep on rolling.
Yeah.
Yeah.
Thank you so much, everybody, thank you.
Well, thank you very much, Dr. McDougall, and to our adults with Williams syndrome. So that is going to be a difficult session to follow, but I promise it will be worth staying. We have a double session now. So the session 5A is an overview of neuropsych testing and navigating the IEP. Dr. Jill Pineda will be giving that next door. And session 5B in this room is education for life, putting it all together, education, social relevance, and executive functioning. And Robin Pegg will be speaking about that here in this room. And both sessions will be recorded and available after today. You gotta introduce me? I don't know if I'm gonna read all of that. Yeah, please don't. Okay, just ignore that and just say whatever you want. There you go. We'll give, there you go. How many people left?
I think bathroom breaks.
Huh?
Bathroom breaks.
Oh, good.
I'm glad they're taking pictures. up here. Okay. Thank you. And then, or you know what? I'll introduce Robin and then I'll come back there.
There you go.
All right. We will get started. I have the enormous pleasure of introducing Robin Pegg. I only work with people named Robin.
That's because she's Batman.
I walked right into that one.
I'll get you a one.
Sorry. Robin Pegg is the WSA educational consultant. And she's amazing. She is an RESNA certified assistive technology professional who has dedicated her career to promoting the full and equal access of individuals with disabilities. She prides herself on staying at the cutting edge of all available tools, strategies, and supporting research in the field of assistive technology. Robin's dual background in occupational therapy and assistive technology affords her a unique perspective when in the pursuit of solution for access. And you have more than 20 years of working with individuals with Williams syndrome. So it's always my go-to person for assisting with the education of your children. So welcome, Robin.
Thank you, ma'am. You never know what to do when that people are doing that. It's kind of embarrassing. So, well, thank you guys all for being here. I don't know how I got the ability to close down the show today, but wow, and that was a tough act to follow, right? I mean, amazing. So we're going to talk about education and best practices and kind of like how most of the themes that you've heard today weave together. So, okay, so the big thing is that it all starts in kindergarten. Do you remember kindergarten? So depending upon your generation, kindergarten might have included nap time in sandboxes, flaming hot metal slides, deadly merry-go-rounds, two things that are outlawed now, teeter-totters. You know, my husband actually has like the end of his nose is kind of messed up from a teeter-totter. You know, having to choose white or chocolate milk at snack time, that was a thing. Learning to print letters and numbers, being rewarded for tying your shoes or losing a tooth. Okay, this is what kindergarten used to be, right? Nowadays, the generations experience brain breaks, zoophonics, single digit, addition and subtraction, beginning to read word family books, and the pace is so much faster now. David, is there any possibility, I'm sorry to interrupt, that I can have a lavalier? Thank you. I'm a little bit of a pacer. I can't stand behind a podium. Thank you. Yeah, I can't do the mic thing because I'm not Beyonce. Thank you. Appreciate that. Oh, careful. Can you hear me now? Verizon, Bueller. Okay. All right. So there was a New York Times article by a lady named Kate Zernike that talked about the pace of academic growth. And one of the things that they've figured out is that the pace of academics and the expectations in academics have grown so much that instead of these types of things on a report card from the 1970s, kids are now doing this stuff, which is, if we compared curriculum, these are late first to early second grade expectations in the 1970s. So what kids are doing now and the expectations that we have are inordinately higher than they used to be. So when we think about that, they not only are higher, they're also faster. So what kids have to do and the actual pace of instruction is so much faster than it ever used to be. And so not only are they expected to learn the academic content faster, they also have to learn how to student faster. Okay, so what does that mean? What does it mean to understand how to student? Okay, so it means you need executive functioning skills, you know, planning, organizing, emotional regulation, impulse control, communication, teamwork, you know, and those look different at all different grade levels. But generally include things like you have to be able to manage your stuff, right? You have to follow a schedule. You need to know who the boss is in the room, okay? And this is especially hard for individuals that, you know, have paraprofessionals, because there is, you know, who's the leader? Is it the teacher or is it the person sitting next to me? Who's my boss in the room? So they don't understand the power dynamics in the room. The other things that they have to do is share and collaborate with their classmates, follow directions, manage their emotions. You don't throw things, you don't bite people, right? That's not, you know, only the teachers, just kidding. All right, they have to take turns and, you know, keep their body fluids to themselves, right? These are important things to do. These are executive functioning skills. So here we go. So now imagine that you're a child with Williams syndrome, okay? Any grade, without any intentional instruction and executive functioning skills, okay? No intentional instruction. So you're probably struggling with how to student. We're struggling with those executive functioning skills. Your body's probably dysregulated at different times during the day. You may or may not have a handle on your emotions. It depends on what happened at recess, or it depends on what happened at lunch, or, you know, in the hallway at high school, whatever that might be. And all your pesky working memory deficits are really get in the way of, you know, they're just a huge pain when you're trying to follow the teacher's directions, okay? So we're in this place with that regardless of your functional learning or functional abilities with executive functioning skills, these people also want to require you to learn stuff. So not only are you struggling with all the executive functioning pieces, you're struggling to manage your stuff, especially if you're in high school. Did you bring the right books? Middle school, same thing. Did you bring the right books to class? Are you prepared? Do you know the schedule? Do you remember how to get places? Have you seen some of these high schools? You could get lost in there for days, right? I mean, it blows my mind. Mind you, most kids with Williams syndrome, I find that they understand the layout of the building and wander around it by themselves pretty fast, which thank goodness, because when I have to follow them around, I'm lost, right? Okay, so, but here's the thing. You have to learn this stuff. So your teachers want you to learn concepts, read, write, compose, do math, learn, care about the world, and all of this. Good grief. You know, and you think as an individual with Williams syndrome, how and why am I supposed to be able to do this? It's all hard. How am I supposed to do all of it? Okay, so what if you feel like you can't? Kids with Williams syndrome, individuals, they often do this thing called perceived difficulty, where they like look at something and go, yeah, no, I'm out, you know? And so, and then what happens is, you know, they start to use some strategies. So what do I do about this? Okay, well, let's talk about your earrings. Okay, or tell me about your dog, or how was your birthday party? Or, excuse me, I just need to go to the bathroom again. Okay, so this is what happens when we don't teach executive functioning. What's really important to understand for people with Williams syndrome is that these skills have to be explicitly taught. They will not be inherently learned. And it's a natural, normal expectation that we have that, you know, as kids mature, that they will just do these things. You can hear it in the sentences. You'll hear parents say things like, They should be able to do that. My other kid can do that. Everyone else is doing that. And the problem is if we don't explicitly teach it, they don't learn it. They might learn some of it, but they might not learn all of it. Okay? So that exact scenario that I described happens in classrooms across America every single day, probably around the world. So here's the thing. If we leave these kids with Williams syndrome without targeted instruction, accommodation, and support, and I'm making this thing echo, and I'm sorry, I don't know what I'm doing wrong. Here's my really good line that I wrote, so I got to read it because I'll mess it up if I don't. It says, we will have a population who knows more about the teacher's family and the geography of the school bathrooms than they do about the world they'll live in, whenever their school career is finished. And that's the truth. I mean, I can't tell you the number of kids that the schools have said to me as I go to visit the various different schools. They'll say to me, so we haven't figured out how to ask the parents about this, but we're a little worried that they have some sort of a kidney problem because they're always in the bathroom. And it's utterly an escape avoidant behavior. So, okay, so what's research telling us about these things? We don't have to go by experience. We can't go by experience. Experience tells us some really cool things, but what's really even better is that we have amazing individuals like so many of the people that you saw today. And then, my personal mentor, Dr. Carolyn Mervis. And the research is telling us all sorts of wonderful things. So let's look at that. There's the answer. What do our kids need? It's all in how they're taught. I'm just going to let that sit for a minute. Because study after study is coming back to the fact that it's not that kids with Williams syndrome can't learn. There were many fallacies for many years that used to be out there. I even said them, could kick my own hiney on that one, but they aren't true. Kids with Williams syndrome can do math. They can learn to read. They can comprehend. They can compose. They can write. They can do all the things. It's just all in how we teach them. So let's talk about that. So as the education consultant for the WSA, I speak with numerous families and work with schools teams every single year on these things. I've also had the very unfortunate privilege of at least once a month speaking with a family or a school team regarding some child that's in 4th, 5th, 6th grade, 7th, or sometimes even 8th grade that's reading and doing math at a K or a 1st grade level. I can't figure that out. Why didn't we sound the alarm? Who didn't sound the alarm? What happened with that? I mean, I remember, I don't know, Terry, do you remember the day I called you crying? Yeah, sobbing, because I just couldn't take it. I literally, that week, I don't know what I had talked to, 4 families, 5 families. I don't know, I was just, I couldn't handle it that day. I called Terry just bawling, because I'm like, what are we gonna do about this? And it's this is what's key. The key is education. The key is getting us to the place where the people sitting in this room aren't just parents, they're teachers, they're educators, and they're therapists, okay? So what we wanna do is figure out how these children are supposed to survive, let alone, we want them to thrive in a world where they're functionally illiterate, because that's what that is. If we're reading below a 4th grade reading level, we are functionally illiterate. And there's no causality for that, given what we understand about the majority of individuals with Williams syndrome. Are there going to be exceptions to the rule? Sure. Mervis and her team have provided us with research that clearly demonstrates time and time again that kids can learn if they're taught. Okay? And so we also know what works because of Carolyn's research. It's funny, Carol and I will get in these little tete-a-tetes where I'll say to her, but I know this works. And then she goes back to the lab. And I don't know if it's to prove me wrong or to prove me right, but she goes back to the lab and it comes back. So, and the big key is that it's not hard. It's simple, explicit instruction. This is one of my favorite quotes from Ann Donnellan, and it says, "The criterion of the least dangerous assumption holds that in the absence of conclusive data, educational decisions ought to be based on assumptions which, if incorrect, will have the least dangerous effect on the likelihood that students will be able to function independently as adults. We should assume that poor performance is due to instructional inadequacy rather than to the student's deficits." So what this means is that sentences like, "I just don't know if they're going to be able to learn that," or "that just might be too much," are baloney. Okay. So what we know is that if we use simple instructional materials, such as number lines, hundreds charts for math, task lists, schedules to support working memory deficits, scripts to help develop an internal monologue to help with navigating social situations, learning things like the zones of regulation so they can better understand their bodies, intense and systematic phonics instruction for reading, liberal use of what we call alternate pencils, which means computers, iPads, labels, label makers, all these kind of things, to mitigate messy handwriting. And lastly, ongoing speech and language therapy to support language and vocabulary development, which is central to them understanding the concepts that are being taught in the curriculum. Absolutely central to that. So all of those basic and fundamental instructional strategies, what they do is they unlock that learner with WS and then open the door to education and autonomous thinking, and so here's what that looks like, right? There's a list, but here's what it looks like. Simple, common things. We make sure that they're tied to the curriculum, they're quick, they're efficient, and they follow the path of least resistance. Okay? iPads. You can use apps like these apps right here, CoWriter, SnapType. SnapType Pro, what the app does is it allows you to take a picture of any kind of a worksheet and then the kids can type right on it. Very simple and easy. I have kindergartners and first graders that can use it. Clicker Writer, Read and Write for Google. These are very common apps that most school districts have access to. Using speech to text. Any of those things, you just turn them on and put them to work for the kids. Chromebooks. Most of the schools in America are using Chromebooks in their classrooms. We have the same things. DocHub or Kami, those are PDF editors, which means the digital copies of the worksheets can be sent to the kids or in a Google Drive or something like that. The kids pull them up, they type right into the PDFs. With their work. Read and Write for Google Chrome. I don't know how many schools in the country don't have that. That number would be probably easier to find because almost everybody has Read and Write for Google Chrome. And what that does is it has word prediction. It also can read text to kids. It's got wonderful outlining capacities, all these different things, there's like 16 different tools in there that help kids with writing and work completion. And then the Bookshare web reader. So as a person with Williams syndrome, your kids are able to get this service, the Bookshare service, and there are hundreds and hundreds of thousands of books and textbooks in there. FYI, they won't ever pay for textbooks in this program, and they are all audio. So they can see the book and it will read to them. You can change the voices. They have way better voices now, which is fun. I know one kid who found one voice and he slowed it down. He slowed the pace of the speech down. It sounded like Yoda. He loved it. It was great. So you can do all sorts of fun things with that. And then finally, some of the best things on the face of the earth are low-tech accommodations. These are those quick and dirty things that work really well for little nuggets and even for older kids.
you know, stickers, mailing labels. When I say stickers, you know, you can put stickers on the keys. If your kids aren't very fast typers or seem like they're doing a lot of the hunting part as opposed to the pecking part, what you do is you get these set of stickers. You can buy them on Amazon for about $12. They're large print stickers and you stick them on the keys. Because it's not because the kids can't necessarily see them, but it's just because it makes it faster. They don't have to look as hard to find a key. So we usually end up getting much faster typing out of kids if we use those. Mailing labels, it's a magical thing. You know, they have all those like word banks and things like that that kids have to do. You just write the things in the word bank on the mailing labels and hand the kid the mailing labels and the worksheet, and they just peel and stick them instead of having to write all the words. It's just so simple. Highlighters, bubble sheets. People are still giving bubble sheet tests. Don't ask me why, but considering we have digital supports and we went through a pandemic, we know how to do it now. But if that's a thing, your kid doesn't get the bubble sheet. What they get is an actual printed out test and they just use a highlighter to highlight the answers. None of this circling business, because that's kind of a pain. Okay, so simple accommodations make a huge difference. You know, George W. Bush has this quote that I love, he says, now some say it's unfair to hold disadvantaged children to rigorous standards. I say it's a discrimination to require anything less. We don't want to fall into the soft bigotry of low expectations. And that's absolutely important because, you know, is every child going to learn everything? Maybe not. Maybe so. We don't know. But I think we have to educate kids with the same perspective we have from a typical child. Just teach them. Just teach them. Generally speaking, no one asks the question with typical kids, you know, can they learn this? They just teach it. And then whatever this is, if the kiddo struggles, you know, or the young adult struggles or the teenager struggles, we address it. And so, you know, Anita Archer is one of the great kind of gurus of education. And she has this phrase where she says, please don't commit a suicide. And I love that phrase because I think that's what often happens. I see time and time again where individuals with Williams syndrome, because they know they have something that ends in syndrome, the kids will be seen, but they won't be seen. So, and we need to be careful of that because our assumptions change our expectations, and our expectations change the opportunities that we give. And then we change their lives and their opportunities simply based on bias. So that's that soft bigotry of low expectations. And we have to be careful of that relationship when we're providing, when we're doing these things. So one of the biggest things that we have to focus on is not only teaching executive functioning skills and helping these kids be able to manage themselves and be a part of their classroom community. The other thing we want to do is work with this concept of autonomy. So many times what you'll hear is we want to work on independence. We always want to work on independence with kids. And, you know, that's all great and well and good. And independence, by definition, is self-sufficiency. It's the ability to complete a task without the physical or verbal assistance to another person. That's great. Autonomy, that's self-governance. Okay, this is the ability to make a decision. Right? I will never ever forget our car conversation, Terry Mankawa. This was a pivotal conversation because we talked about this. I was sitting in the back seat, Terry was sitting in the front seat, and we just had the best conversation about this idea. It's all well and good to teach people skills, but if they don't know when they ought to do it, or if they ought to do it, or why they ought to do it, what's the point?
This is another thing that we need to explicitly teach. I was just talking about a kiddo the other day where the teacher said, he knows all of his math facts, he knows all of these things, he knows, all of these parts, but like, he just doesn't know when to do what or why he should do what. He doesn't understand the concept of math. And I'm like, well, have you taught that? And she's like, no. There we go. That's the missing piece. That's this piece, right? So understand that to be completely independent, you need to be able to do a skill on your own, and you need to be able to know if and when you ought to. I mean, and think about the narrative that we heard up here. Becky was sitting here, and when mom said, please talk about where you're going to live, and she's like, I'm going to live with myself. Like, that shouldn't be amazing. That should be normal. So getting an education, like I said, that stuff starts back in kindergarten. We have to, come around to teaching people this stuff early, right? So here we go. Independent skills without autonomy. They know how to do the skill, but they rarely or never do it on their own. This is where you're like, go get dressed, go get dressed, go get dressed. Did you put your shoes on? Did you put your shoes on? Did you do it? It's that kind of thing. Autonomy without independence. This can also be a thing. An individual who knows what he or she wants, but they can't complete the task. But let's think about that. Let's think about people that falls into this category. Stephen Hawking. Does anybody question that man's intellect? Does anybody question his abilities? Does anybody question who he is as a member of the community? Nope. Was he independent? Nope. Not even slightly at the end. But he was absolutely autonomous. Superman, Christopher Reeve. Independent? Nope. Autonomous? Absolutely. So this piece is, again, something that we need to teach. And here's the thing. When someone can make their own decisions and they are seen as capable, what is the social perception of that person as opposed to someone that you feel like you have to take care of, that you have to help with everything? Percolate on that for a minute, because what you'll see is those things impact relationships. They impact how we see people. And for kids at school, if a child is seen as capable and autonomous and makes decisions and is a part of things and knows how to follow class routines and can, turn their work on time and et cetera, et cetera, et cetera, their sort of street cred, their social capital increases. If they are seen as someone who has to be constantly supported, better do it, better do it, better do it. If this is the case, then that social norm is copied by peers, and then relationships are not true friendships, they're more benevolent relationships. So it impacts social capital. So this is what this looks like. Carol and I worked long and hard on this graphic. So autonomy requires executive functioning skills and social capital, and autonomy increases social relevance. So like I said earlier, simple targeted instruction in academics and executive functioning skills are the tools that support an individual's ability to develop autonomy. And having autonomy means a person has decision-making ability, okay? And while it's important to develop independence, but if you have skills and you don't know when or why to use them, you're gonna be stuck, paralyzed, waiting on go, right?
and for somebody to tell you what to do next. It's like you need a human GPS. So the ability to make a choice or decision is a skill, and we have to teach it explicitly, just like everything else. So most of all, as you've heard many, many times today, individuals with Williams syndrome are engaging individuals who deeply care about others in the world they live in, and providing these people with an education teaches them to explore the world they live in through literature, poetry, science, geography, everything, etc. It also ensures that these individuals have the background knowledge that they need to make better decisions, to advocate for themselves. And, I think back to the very first talk this morning about sexuality and the ability to understand and be able to communicate, what's right and what's wrong. That skill set ties into all of these skill sets. People with WS are often vulnerable and they can be easily taken advantage of. And unless we arm them with skills around autonomy and skills around decision-making and executive functioning skills, they're going to fall prey to more bad things out there in the world. So we owe it to them. I guess that's what I'd like to say, is that we owe it to them to arm them with as much information and as many skills as possible, so that when they go out into the world, they're as prepared as possible, and whatever that means to them. In other words, I leave you with this. We have to teach the world for them to reach the world. And that's kind of the last thing I just want to say today, is understand that as much as we teach math and reading, as important as those things are, we have to teach executive functioning and we have to teach autonomy. And if we do those two things, we're going to have much better results. And I just have a couple of minutes left, but I just want to tell you the story behind, I don't know, David, can I go back a slide? I don't know how to do that. Oop, previous, This young lady right here, she's graduating from high school with a New York State Regents diploma. She passed every single Regents exam. But here's the crux of the matter. She never stepped foot in a general education classroom until 6th grade. The school knew she had Williams syndrome, so she went into a program classroom and she stayed in a program classroom until her parents fought the fight. As of 6th grade, she became fully included in classroom and started to work. Now, did she put in hours and hours and hours of after-school tutoring? Yes, she did. She's at Syracuse University right now. She takes classes for credit. So I'm just saying, is she an exception? Yes. That's absolutely. But here's what we know for sure, is that these kids are capable of so much, and we just have to teach them. Thank you. Okay, I think there's a mic somewhere.
Thank you so much for that. I'm a parent, obviously, and I'm also a teacher. And our daughter just started kindergarten a couple of weeks ago. And I guess I'm wondering where the rubber hits the road in your talk. It's like our daughter is in an inclusion classroom, but where, as a parent, where should I spend my energy in terms of supporting her individual teacher and getting this kind of information she needs, supporting the school as a whole, knowing that she's going to be moving to 1st grade, 2nd grade, 3rd grade. Some people even move districts so that they can go to a better school system. Like, what do you think is the most effective way to access the best education for a child with special needs?
So I would say for a child with Williams syndrome in particular, you want to get the educational profile, and we just updated the educational profile. It's on the WSA website. Get that in the hands of your teacher. Okay. It should be. Sarah, let's make sure we upload the PDF. So you want to get that in the hands of the teacher.
The other thing that you want to make sure that you do, especially if this is your school that you're going to be at, is see if you can get in front of all the teachers. See if you can offer them an hour of free PE. And, either myself or Michelle Self can do a training for all the teachers, just to kind of orient them to kids with Williams syndrome, as she's going to be moving up through the ranks. The other thing that I would say is, if she can go to school in her community, that's the best thing, because what you want is when she's hitting middle school and high school is you want to be like, Mom, I want to go to dance with Sally. I'm going to go to Sally's house and we're going to get ready, when she's in 7th or 8th grade. And, you want in high school, the car full of teenagers pulling up to your house to get your kid to walk out and go to the football game. That's the stuff that you want. So stay in your community if at all possible. The other thing I would say is that at kindergarten, please, 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 get some sort of technology in her hands, because you need to get those skills started early. The pencil's going to be a problem, and especially with the pace of instruction being what it is, they will start to the schools inadvertently hold back other instruction because the handwriting isn't there.
So I actually have a somewhat different perspective. As you've heard before. So none of the adults live alone that I follow. People who live alone have a high level of support, basically sleeping in their own place at night, but doing everything else with family or staff. Now, admittedly, those people are 40, 50, 60, and didn't have some of the benefits, so that it's possible, but I feel like I see a broader perspective. There's a huge range in Williams syndrome.
Yeah, I agree.
I mean, I think it's always important to ask what if they can, but the caveat for me is when I hear from high school students who finally say, I'm just tired of not being able to do. Now, maybe the instruction was dreadful, but there's been an effect on their self-esteem.
Yeah, huge.
So, either we have to get everybody from a teacher point of view to be able to instruct properly, or there's a fine balance between instruction, but continuing to, again, support people's feelings and images of themselves.
Yeah, I utterly agree, Barbara. I utterly agree. I think generationally, the adults that you see, they absolutely didn't get an education that, worked for people with disabilities. I mean, our educational practices were so much more ableist.
But I guess, are we so much better today?
We're getting there. I think we're getting there. And I think the only way we're going to continue to get there is because people keep sounding the alarm that it's not okay for a kid to be 7 grade levels behind in reading, and that's the stuff. This a squeaky wheel gets the grease. And I think we just have to keep squeaking. That's the only way we're going to create change.
I feel like we are way better now.
I mean, I think we are too, but you even saw from those adults whose age range is basically, those were all 40 to 50 some odd year old folks. They do all have anxieties. It doesn't, as soon as you start asking, you don't have to scratch the surface very deep.
Yeah. I just love, to your point though, Barbara, I do think that the biggest thing is to be really honest about it, and when the kids are older, you know, especially like when they're hitting high school and things like that, if going to a post-secondary college program isn't something they want to do, okay.
Right, and we've talked, yes.
Yeah, that's fine. I mean, you know, do they want to go to a tech school? Do they want to go to, you know, do they want to go to, you know, a day program? Do they just want to work in the community? Like,
Or do
what
they-
is it they want to do?
Most of them want to stay home and watch TV and listen to music,
Yeah,
unfortunately.
let's not do that though.
Which, you know.
Yeah, you know,
is-
but the other
is not
side of it
a
is
good
too, is
goal.
like these skills, especially of executive functioning and autonomy skills, those skills can be taught at any age. At any age, and you know, and they should be.
Right, and to me, it's one of the big bugaboos. We have early intervention, we need adult intervention. At 22, when, you know, you graduate, you know,
Yeah.
you're done. What skills you have, they're yours.
Yes.
And to be able to continue to work on all of these skills lifelong, I think is really important, but that's a tangent.
Yeah.
Um,
Yeah, other thoughts, questions?
So our son is 11 and he's currently in 6th grade, moving into middle school next year. Our middle school is 7, 8. But he has been, honestly, our elementary district has been incredible, which is probably why I'm so worried moving into middle school, because we're already being told, like, he's been fully included. He's had a one-to-one para in order to make that possible. He has succeeded amazingly, but we're already being told that next year moving into middle school, more than likely, he's going to be more sub-separate rather than like included, because things are getting harder, things like it moves faster, it's more advanced in middle school and high school. But where do we find that balance? Like the social aspect and everything is so important for him to be fully included. I don't want him to be sub-separate, because like his teachers are amazed at what his abilities, like sitting in a classroom and learning science and being able to like identify different like types of waves and the different parts of the waves and things, maybe not as many as the other kids, but almost just like the other kids.
Right.
But because it gets hard fast, how do we know how much to push? How much to say, no, you're not gonna pull them out?
So a lot of times, when kids with Williams syndrome hit middle school, high school, depending upon the kids, there's a few different instructional models at those schools. So you'll have what's called like a categorical program, or depending on your state, the 12-1-2 programs or the 8-1-2 programs, or you know, whatever they call them. And those are for the kids with the more significant needs. And then there's usually like a bridge room, so some sort of a transition room where the kids have less needs, right? And then sometimes there's like a resource room or a teacher consultant model. And so what you'll see is kids ask about like a transition classroom or a resource room. More often than not, that is the place where kids with Williams syndrome usually are, is in a resource room. And they usually get resource room for reading and math, those sort of core, and then everything else is in the gen ed.
That's how it's been.
Yeah.
Moving into middle school because those other things are harder.
And some schools have like a resource science and a resource social studies, or they call them a transition class. Ask the questions and ask if they have co-taught classes where there's a special ed teacher in the room with the gen ed teacher. You also want co-taught classes, you know, any of those places where you can sort of like sit on the fence between the two things. But ask the questions, ask them what's their sort of span of services, because they might just not be telling you about all that's available. And then you can pick. So, okay, sorry.
Thank you, Robin.
Yep.
Well, thank you everyone for taking time out of your Saturday to be here this afternoon. And thank you all to all the wonderful speakers who are here as well. We have the space until 5:20 to mix and mingle. We hope that everyone has learned at least a few new things and made at least one new social connection. Please know that every aspect of this meeting was covered by donations, ranging from the gift from the Philip Hazo Fund to use the space, a gift from the Burnin family that supports all of Cherie's time, and donations to cover the snacks. We, the leaders of the MGH Williams Syndrome program, believe that events like today's are incredibly important with educational and social benefits, and we're committed to continuing to hold them. To do so, though, the program will need ongoing support from the Williams Syndrome community. Finally, please be on the lookout for an email from Cherie later this week. We'll have a little online survey so that you can provide feedback from this event. We promise we'll read every response and we will use it to try and improve future events. Thank you.
I imagine, well, if there are questions, I imagine there's still food. If people want to mingle over there for a couple minutes, that'd be great. Thank you. Thank you so much for making this event this afternoon really special. Thank you. Are you gonna hop on? Yeah.